Okay.
Yeah, you take the snap.
I think you need to stop share the screen.
Yeah, you'll have to unshare.
Just 1 minute. Just give me 1 minute. Today I'm using somebody else's laptop. Full screen. Yeah.
So I think I'll request everybody to please switch on their videos so that we can take a quick shot. Everybody to please share their Dr. Yeah. Dr. Arul Mozi. So yes, smile. Thank you.
We are live.
Okay, we go live.
Yes, sir, we are live.
PowerPoint. Full screen. So, full power show का slideshow. Your system, Tanish. So, just Sunil, just give me 10 seconds. I'm not getting the slideshow button actually.
You can do it from the top.
Yeah, that's what I'm doing, madam.
No, it's there on the 5th or 6th column, right side.
Yeah.
No, and one more. Shift one more.
One more. Yeah.
Yeah.
Yes.
My son's laptop, so I'm not used to it. Okay, so good evening, everybody. Welcome to this AIOSSC Scientific Committee webinar, My Unhappy Patient. We all have been watching webinars with various specialities, but I think Scientific Committee has come up with a very different way of presenting in a webinar, wherein we are talking about my unhappy patient. It takes great courage for anybody to present about his unhappy patient, the story of his unhappy patient, how they have made the patient happy or still is the patient unhappy, what rectification can be done. We have our chairperson here to solve it. So it takes great courage, and we have great speakers from Pan India, and we have great chairpersons and judges to evaluate these presentations. So I welcome everybody. I welcome President AIOSSC, Dr. Mahipal, Secretary AIOSSC, Dr. Namrata Sharma. We have our chairpersons.
Just slide up, move.
Yeah, I have not started introducing yet. We have our chairpersons. This is the Governing Council. We thank our AIOSSC Governing Council for supporting us throughout our scientific webinars. And in Scientific Committee, that is Dr. Amit Purwal, myself, Dr. Feiruz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kudlu, Dr. Parikshit Gokte, Dr. Somshila Murthy, and Dr. Sonu Goyal. This is a team of Scientific Committee who do a teamwork and are always united to do any scientific activity. We have our chairpersons, President AIOSSC, Dr. Mahipal Sachdev, Chairman and Managing Director, Center for Site Group of Eye Hospitals. Professor Namrata Sharma, Secretary AIOSSC, Professor of Ophthalmology, Cataract, Cornea and Refractive Services at RP Center, AIMS, Delhi. Our Chairman, Scientific Committee, Dr. Partha Biswas. He is the Director of BBI Foundation, and he is the Chairman of our team Scientific Committee. We have Dr. Girish Rao, who is the President, MRF, Shankara Netralaya, Chennai. Dr. YL Rajshekhar, Founder and Medical Director of Shekhar Eye Hospital, Bengaluru. Welcome, sir. We have Dr. Virendra Sagwan, who is the Associate Director, who heads, he is the head of Srujana Center for Innovation and as well as the Center for Ocular Regeneration, a joint venture of LV Prasad and Massachusetts Institute of Technology. We have Dr. Arul Mozi Varman, Medical Director of Uma Eye Clinic from Chennai, and Dr. T. Nirmal Frederick, who is the Managing Director of Nirmal's Eye Hospital at Tambaram. We have Dr. Pradeep Vyas, who is the Senior Consultant at Center for Sight, a leading glaucoma practitioner in Indore. Dr. Sunil Morekar, who is the President of International Society of Oculoplasty and Reconstructive Surgeons and Consultant at Kumbhala Hill Hospital, Kemps Corner, Mumbai. So, we are not wasting much time. Just as an opening remark, I request Dr. Namrata Sharma and Dr. Professor Mahipal Sachdev to give a few comments on this webinar.
I don't know if sir is there or not.
He's not logged in. Madam, from your side.
I think I would like to congratulate the scientific committee, the entire team, Dr. Partha Biswas, Parikshit Gokte, Somshila, Amit Podwal, Sonu Goyal, KP Kudlu, all the members of the scientific committee who are doing actually a great job of doing these webinars. And like Amit very rightly said, it is very difficult to share your unhappy patients. Happy patients, good edited videos, everybody shares, but unhappy patients and badly done surgeries and complications is something which people don't like to share. But it helps each one of us to learn from each other, and a very nice concept, Amit, and wish you all the best for this webinar.
Thank you, ma'am. So without wasting time, I invite our scientific committee member, Dr. Somshila Murthy, to begin with the first presenter. Dr. Somshila, over to you.
Somshila, unmute yourself, please.
Yeah, thank you, Amit. Very happy to be part of this meeting. I think that this is one of the ideas that the scientific committee is always trying to look for things that are different and try to bring about new concepts for us to discuss at the meeting. I'm just trying to share my screen.
So meanwhile, I'll just like to pitch in and say that it's a 4-minute presentation followed by a 4-minute discussion. And there'll be 2 lead discussions for each presentation. Yeah, Somshila.
The first speaker is young Dr. Abhinav Biala. He's one of our new faculty at L.V. Prasad Institute in Hyderabad, having done his fellowship in comprehensive as well as cataract and refractive surgery. And apart from that, being a very competent surgeon, he's also part of our education activities, as well as being an excellent cataract and refractive surgeon, and he's going to share his case. So I invite Abhinav to share his case.
Thank you, Dr. Somshila, for the kind word.
Abhinav, I don't think you're loud enough.
So, is the audio better now?
Yeah, it's better. Just speak up, please. Though.
Yeah. So, my slides are visible, right?
Yes.
All right. So, good evening, everyone. At the outset, I would like to thank All India Ophthalmic Society Chairman, the Scientific Committee, for giving me this opportunity to present our case of this unhappy patient which we had. So, I have no financial disclosure. The patient was a 25-year-old male who came to us with diminution of vision in both the eyes, and he also had alopecia, for which he used steroids in the past for 10 months. On examination, he had this cataract, which was P3 on the LOX 3, and it was a steroid-induced cataract. It was there in both the eyes. Also, the patient was very learned. He had come to us with all the information about multifocal lenses, femtolaser assisted cataract surgery after reading up it on the internet. So after all discussion with him, we decided to implant extended depth of focus lens. And on the A scan, we saw he had significant astigmatism in both the eyes, which was with the we planned the right eye first. So we also did a pre-operative tomography to see whether the astigmatism findings were corroborating or not, and they were pretty much same on the tomography as well for the right eye. Then we fed in all the values in the Technis toric IOL calculator, and it gave us an IOL model of ZXT300, which was supposed to be implanted at 102 degrees in the right eye with a superior incision. So the intraoperative course was perfectly normal. We went ahead and did a manual marking both pre-operatively as well as intraoperatively. On the first post-operative day, he had an unaided visual acuity of 20/30, which with an unaided near vision of N8. But to our surprise, his visual acuity in the right eye had dropped to 20/60 at the end of 2 months of the surgery, with a significant residual refractive error, as you can see in my slide. In between, he had also undergone the left eye cataract surgery with the same Symphony toric IOL, which had a good refractive outcome. Then we went ahead and we started analyzing that what was the cause for that refractive error. So we did an eye trace, and we saw that the eye trace showed that the IOL was slightly off axis and it required a little bit of rotation so as to have a good post-operative outcome. Similarly, we also got a post-operative tomography done so as to rule out if the surgically induced astigmatism or the incision was causing any significant astigmatism. But that was not the case, as the pre and the post-op values were almost the same. So finally, we dilated the patient, and we saw that the IOL was definitely not at 102 degrees where we had intended it to be. And so we thought that what could have been the cause for this rotation. So very often, if we don't get the pre-operative manual marking right, it can just lead to a downhill course, with the intraoperative alignment also being wrong, because our pre-operative manual marking is not accurate enough, as we use the Mendes ring to with the pre-operative marking as the reference points. So any amount of viscoelastic which is left behind, suppose if it's not cleared off and before doing the final axis alignment, again is one of the causes. Also, intracameral antibiotic and wound hydration do raise some fluid waves in the anterior chamber, which can again lead to a slight shift in the final post-operative axis. So we took help of this calculator by Dr. Gordal and et al., where you need to put in your post-operative refraction, and it tells you that by how much you need to rotate the lens. So this this calculator also told us that the IOL needed to be rotated by around 160 degrees to have a good post-operative outcome. So we took up the patient for surgery for IOL redialing, and this time we took help of technology. We used the Callisto image-guided system, so as to have a post-operative axis at 102 degrees, as we had planned in the first surgery. At the end of 1 month of redialing, the patient did have a good visual outcome according to us, but he was not very happy with the fact that we were not able to get it right in the first surgery. So that's regarding my case.
No, Somshila, we can't hear you.
Thank you very much, Abhinav, for presenting this case. The discussants for Dr. Abhinav's presentation will be Dr. Varman and Dr. Rajshekhar. So I'll invite Dr. Varman to first give his comments or about this case.
Thank you, Somshila. That was fantastic. Nice presentation that shows how you have to get it right the first go, particularly for toric IOLs. We couldn't really find out what was the cause of misalignment. I'm sure that the manual marking was accurate. So probably we have to put the blame on when you finally hydrate, you do a fluid wave. As the presenter said, and the bag can inflate. And when the patient moves, it can rotate. But most often this rotation occurs in the first 6 to 8 hours. So it's kind of surprising that the patient was quite all right on the first post-op day, and the rotation took place later, which is quite surprising. That's a surprising part. So again, when we look at the microscope view, you really don't see much capsular fibrosis or anything that could have made the lens rotate. So we'll have to just think that the bag kind of inflated post-operatively, maybe a day, 2, 4, or 5 days later, because small amount of viscoelastic left on the posterior surface of the lens could have caused osmotic pulling in of fluid, and the bag would have inflated late in the post-operative period. And when the patient came back a month later, you've seen this surprise. The other issue is with these single-piece lenses, which are not plate haptic, when you want to rotate them anti-clockwise 20 degrees, you go around 150 degrees almost. That does make it a little difficult, and you need to really open up the bag fully and make sure that you use a good high-quality viscoelastic and you rotate it carefully by manual technique to get it perfectly aligned. And this time, make sure that you leave no viscoelastic behind.
So just wanted to share that I was the operating surgeon. This is my patient actually. So Abhinav was kind enough to be with me and support me. It was a very challenging patient to handle. He was very, very unhappy. So it was a perfectionist kind of patient. So Dr. Rajshekhar, can we take your comments for this case?
Yeah, Dr. Arun Modi, he covered the technical part. Coming to the unhappiness part, you could have expected it from the beginning itself, because it's a 25-year-old patient who is to start off itself, it's not the age for getting cataract, and steroid-induced element is there. And there is a kind of anti-doctor or anti-medicine mindset in him. And coming to toric lenses, I always tell that cylindrical power will reduce and it won't become zero, because you have a lot of limitations. The astigmatism correction you get only at 0.5 increments, and 102 degrees and 107 degrees are going to be different again. So it's best to set an expectation there. And most of the times they should be, our optometry team has to be sensitized with regard to the AR readings. Autorefractor readings will go wrong in these cases, and if they see those, if you are each time you are taking that printout to compare, again you will end up with basically it's a well done surgery. Technically you have used the best possible things, but patient is not happy because probably we have set his expectations wrong in this. So in toric lenses, setting expectations right and not playing to the gallery is extremely important. Just say that 1.75 cylinder will come down to 0.5 or whatever. That should be fine. And toric and multifocal is always a challenge.
Dr. Rajshekar, they are very, very valid points. Believe me, I set his expectations so low that I told him that you will get glasses post-op.
In India, that happens, ma'am, because see, whatever you are talking, they go by your reputation. They say that, oh, ma'am, I say Kete, and finally she'll do well. And then they'll also say, we leave it to you, God is there. And finally, that means that you have to set it right. It's everything else is your headache. We find this.
So I think funnily it was because the other eye did so well. I think that contributed to his unhappiness.
Somshila, can I just ask one
Yes,
question? You had a Callisto in the first instance.
Yes.
So why you did not use Callisto on the first instance only on the table?
So we have very high volume of cataract post-COVID. And each of us has our own OR, and sometimes very hard and very difficult to share the OR. And this patient came at that particular time, and I would have to wait several hours for this kind of patient. So I was fairly confident because I'd really set his expectations so low, saying that come what may, you will need glasses. Because you know that symphony lens doesn't give a very good close-up vision, only intermediate. So I did my best, but for the left eye, it worked very well, not for the right eye. So it was a logistical reason that I couldn't use Callisto. And of course, now I've learned my lesson that always use it.
No, one more thing while we are, because at the Alcon session, I think Aura is a great tool also.
Yes, of course.
It gives you an intra-op refraction, especially for toric IOLs, because it gives you an endpoint saying that no rotation is required. And only thing is that you will have to have a couple of lenses with you because you may have to change the lenses. So that kind of inventory is required. But it's a useful tool to have for toric lenses and also for post-refractive surgery cases.
Amit, how are we on time?
Oh, yeah. See, Callisto, no, like viewers shouldn't go with the impression that Callisto is a must for doing. Toric lenses. So you can do very well. In fact, for the second surgery, they used Callisto, and still patient is not happy. So like, because again, we'll introduce another parameter and confuse the patient. Same patient will come back and ask Somshila, why you didn't use it? That's why I'm unhappy. That will add to the problems. We introduce words and we'll add to our own problems.
I think always market our skills and not the instruments, I feel.
Yeah.
But
Aura or Callisto to the patient.
No, do not tell the patient. That is for internal discussion.
Yeah, internal discussions. Yeah.
For the patient. You never tell the patient what tools you are going to use. But then these are techniques and technology which is, just helps to refine those things a little better.
Yeah, Somshila, it's good to have unhappy patients so that doctors can always remain grounded.
but you don't have any, so you're the wrong person to say that. Quick question for Abhinav, which I wanted to ask. Abhinav, since you analyzed this case of mine, would you now recommend that on the day one post-op also we should dilate and take a look at the axis? I think that is a good practice to have, but would you recommend that now?
I would not say on day one, but yeah, probably on day 7 it will be a good idea, because the literature also reports that the rotation usually happens somewhere between week 1 to week 3. So I think the first post-operative week, the day 7 or maybe the day 10 visit or probably day 14 visit will be a good, in case you don't see a good uncorrected visual acuity, it will be a good idea to dilate and see the actual position.
My question, I have a question for Dr. Weiler and Dr. Arun Mozi. If you see the first post-op day, lens is rotated, slightly rotated, say 5 degree to 10 degree. Will you take him immediately to the OR to rotate, redilate, or will you wait for a week?
Okay, I'll put it this way. I actually check every one of my patient immediate post-op before they leave home in a couple of hours after surgery. We look at if the pupil is still dilated, we try to see whether the lens is in position. That's the most critical point. You would find most of your rotations would occur at that point. If that occurs on day 0, I take the patient back to the OT right away. On day 1, it ought not to have rotated. If it rotated day 1, I'll go back to the OT again right away. But if it rotates after a week, then I'll probably wait 2 to 3 weeks for the back to shrink a little, then go for the re-rotation.
Okay. Dr. Weiler?
That in my practice, I have kept little more tolerance limits. So we don't do immediate checkup of all these refractions on day 1 and day 2 and all that. We'll see the refraction. If it is within 0.25 to 0.5 cylindrical power, we just allow it there. It's because astigmatism is not bad, and even up to 0.75, we are not correcting. Then if you go on doing this fine tunings, you will introduce more parameters, risk of second surgeries, setting expectations further high, and getting into issues. So that's why I just leave it at that. Like, if a patient is having 0.89 astigmatism, which power you will choose? Where are you then? Again, you will have to go on this side or that side. So there is a tolerance limit. As long as you reduce the astigmatism, I think that should be good enough is my approach. We have rotated few lenses. That's because of the wrong marking that has happened in the preoperative. And intraoperative, he specifically told you do a good washout, leave the AC tight. And each time you position the lens, you have to come clockwise. Suppose you have gone even 5 degrees clockwise, and then you try to adjust it by coming anti-clockwise, it doesn't work. Again, you have to come the clockwise because of the kind of the loops that are there. If you follow those techniques, mostly it will stay as you have left on the table. So you have to spend little extra time. All my surgeries, Toric, take at least 5 to 10 minutes extra time because you have to be that patient to wash out the visco and put it positioned right and keep the AC tight. It will work that way. And we mark the axis at which we have to put the lens. We don't go at 180 degrees and again put another, because you will be introducing 2 more parameters. Pre-op, you mark where exactly you have to put and align the lens and leave it at that.
Thank you very much.
Somehow it's working.
I would just like to pitch in and just highlight 3 intraoperative points that are very essential. I think very rightly said, tapping the lens is very important, washing the viscoelastic behind the lens, and not over-inflating, because the moment the back gets over-inflated, there are more chances of lens getting rotated. So I think an average hydration is what is important, and over-hydration should be avoided. And secondly, any refraction day 1, if you have a combination of plus and minus, that always indicates that yes, the lens has rotated. And you don't need high gadgets. I think the software on the internet, the astigmaticfix.com, gives you a fair idea, how to chip in and how to correct. And day 1 is the most important day where you should look in. I mean, immediate post-op is the maximum rotation that occurs, I think. So very rightly said by Dr. Varman, we should immediately, after this surgery, after 2-3 hours, take a slit lamp examination. And that gives us, because early rotation most commonly occurs within half an hour. The moment you shift the patient out, that is the time when the rotation occurs. Somshila, all yours.
Yeah, so it's a very interesting case, but we have so many more interesting ones coming up. Moving on to the second presentation, I'd like to, before that, thank Dr. Rajshekhar, Dr. Varman, and thank you, Abhinav, for presenting my case. The second presenter is Dr. Vivek Singh, who's one of my young colleagues at LV Prasad. He did his DNB and fellowship at LVP, and also is in the cataract refractive team, one of the very talented surgeons, and he's going to share his case with us. So over to you, Vivek.
Thank you, Dr. Somshila, and thank you, AIOS at the outset, just to allow us to present our cases in front of such galaxy of stars. And moving from a surgeon who was a master in cataract surgery to her apprentice, and I'll be presenting this second case. My patient presented to us in January 2020. He's a 45-year-old gentleman, and he presented with both eyes blurring of vision since 1 year. He's a known case of diabetes. diabetes mellitus. He presented to us, his vision was hand movements in the right eye, and his visual acuity was 2600 in the left eye. He had a senile mature cataract in the right eye and a significant amount of cataract in the left eye as well. So we decided for the right eye cataract surgery, and this cataract surgery was performed in March 2020, and phacoemulsification was done clear corneal under local anesthesia. There was hardly any astigmatism, as you can see in this patient in the right eye. And we chose, a patient had opted for a hydrophobic acrylic lens. We chose a Technis lens over here with minus 4.2 of residual myopia. On post-operative day 1, so the intraoperative course was also uneventful. On post-operative day 1, the patient was comfortable and he did not have any complaints. The visual acuity was 20/40, improving to 20/30 with the pinhole. When he presented to us at 1 week, again, the patient was comfortable. His visual acuity was more or less the same. At 1 month, the patient presented to us. This time he started complaining of some photopsia, positive photopsia here. His visual acuity was 20/20 with plus 0.75 spherical error. He started complaining of glare. This usually happened when he used to go for nighttime driving. He was comfortable during the daytime. And he was keen on left eye surgery as well at the same visit. However, the COVID lockdown ensued and he could not get the left eye surgery done. This is the 5th month post-operative visit, and he visited us in one of our secondary center. This time the visual acuity again was 20/20, and he continued to complain of the glare during the nighttime driving, and he was comfortable during the daytime. And again, he wanted the left eye surgery. This time he could not travel to the tertiary care center, so he decided to get it done at the secondary center. At secondary center also, the same lens was implanted with minus 0.5 residual myopia. And this time he was very comfortable with the left eye. The symptoms continued for the right eye. His visual acuity was, this was the refraction at 1 month. He was 6/6 with 0.5 residual error, 7.5 residual error in the right eye and -1 slender in the left eye. So because of the complaints of the glare, especially during the nighttime driving, the surgeon over there advised brimonidine to be used twice daily for him in the right eye. And this was the 1 month visit after usage of brimonidine. He was not at all comfortable and he wanted some solution for the right eye. He could not tolerate the lens in the right eye. Now, this is almost 7 months after the surgery. So he was referred again back to the tertiary care center, and this was the slit lamp picture that was that you can see. This is for the right eye. There's some amount of trace posterior capsular opacification in the inferior part. The lens is very much in the back. I'll just show you the retroillumination picture. Now, this is very interesting. Now, if you see the lens and if you see the entire limbus, so if you can see this lens is almost decentered a bit nasally. And if I have to trace the entire rhexis margin for you, this was the rhexis margin. So there was a kind of overlap of around 0.25, 0.5 nasally. However, at this area, there was overlap which was lesser than 0.25 or 0.5. However, this area has a perfect overlap, but this area had slight lesser overlap. And the decentration of the IOL can be made out. This was the other eye surgery, left eye, which was done in the secondary center, which has a very well-centered IOL in the bag and a very a perfect rhexis, you can say. So in the retroillumination picture, you can make out the rhexis over here, and the lens is very much very well centered. I would not discuss. I would not go with the review of literature because I would want to hear from the masters over here. Yeah. So there are what are the possible reasons what made our patient unhappy here? Was it the lens edge? Was it the PCO? Was it the decentered IOL? Or could it be the high angle kappa? The lens was very much in the back. So could it be the high angle kappa? And my second question to the panelists would be, how would you manage this patient subsequently? Because the patient wants a solution now. Would you go ahead with a large optic IOL, or you would consider a piggyback IOL, or you would want to exchange the hydrophobic acrylic lens with another material lens, or would you perform an yak cap? So over to the panelists.
Dr. Virendra Sangwan and Dr. Namrata will be discussing this case. So maybe Abhinav, you could still share, sorry, Vivek, you could still share the first part of it.
So I think this is a clear-cut case of dysphotopsia. And I think it was Vivek who was presenting. No, you said Abhinav?
No,
Vivek.
I corrected myself.
Vivek was presenting.
I corrected to Vivek. Yeah.
Yeah. So I think very clearly and nicely you've shown that the nasal part is the one, which is the overlap is there on this side and not there on that side. Was angle alpha, measured pre-operatively in this?
No, Doctor. Namrata, it was not measured
So I
pre-operative.
think that is one thing which is very important, not only for premium IOLs, but also otherwise. And the edge phenomena is causing dysphotopsia in this. What about the other eye? Do we have the other eye picture also of
Yes, Dr. Namrata. So this is the other eye picture. It's very well centered, and this is the rexus margin that is perfectly overlapping the lens from all the sides.
So that is, something which is little intriguing in this, because it is there in one eye and it is not there in the other eye, and his problems are similar, in both the eyes. But does he experience glare even with the closing of the other eye, the right eye?
No, Dr. Namrata, he doesn't complain of the problem in the left eye. He's complaining only
In
about the problem
right.
in only the right eye. Yes.
So I think it's a very good case control kind of a case where, one eye is showing this and the other eye is not showing. And obviously there is dysphotopsia that is present, which needs to be taken care of.
So how would you manage this case, ma'am?
There are several ways in which, people have tried to manage it. One, you yourself said that, yeah, capsulotomy, some people even try to, remove that edge. Some people try to exchange the lens. So I think that is going to be very drastic. But on brimonidine, he's not, there is no response on brimonidine.
No, he was not very comfortable after 1 month of usage of brimonidine. And there was a trace PCO, the edge of which was coming into the visual axis, if I can share that picture, this one. So if you want to try the YAG capsulotomy first, and just in case if the patient does not improve, and then you want to plan the secondary IOL, that would be a bit tricky. So what would you do in such scenarios?
In my opinion, this photopsia is not, it is actually not coming because of the PCO. I think it is because of the overlap, which is a mismatch on the nasal and the temporal side. So there are several mechanisms or several options described for this. And one of them is that you can implant a very late, one of our residents has described, you can implant a negative dysphotopsia ring inside. So that also can be done. But YAG capsulotomy, I think, will not be done.
Namrata, just a minute. Can you tell me how would you make a distinction between whether the effect is due to the lens edge or due to the PCO? Is there any way to make a distinction pre-operatively without any intervention?
Because PCO is only present inferiorly, if I can see it more inferiorly, then it's not there that in the center.
But the edge also, see the
center is there normally in most patients. I mean, even if it is there in normal patients, also will not lead to so much of glare, an incapacitating kind of glare, which one complains of. One may complain of diminution of vision, slightly with this kind of a PCO, but glare with this kind of PCO, I don't think is going to occur.
Can I just make a comment, ma'am?
Yeah.
Yeah. I think the mere fact that this is occurring particularly during night driving, it indicates that the pupil is dilating and it is the lens edge which is responsible. And the PCO which is there is almost below the center. So that may not be the reason, because the night glare is the main problem. So positive dysphotopsia, although it can occur because of some PCO, but I think the lens edge which is there, the mismatch between the overlap of the anterior capsule and the edge, that seems to be the more likely culprit in this case.
So I agree. Yeah, I think I quite agree with you on that, Dr. Bhalla, that it is the lens edge probably which is, which is causing a problem.
So this slight decentration of the lens where there is little less overlap on the temporal side, I think that maybe seems to be the culprit. So if we do YAG capsulotomy in this and later on rotation or exchange is required, it becomes more messy and difficult. So I think YAG should not be done.
No, YAG, I completely agree, should not be done. But how much of time did it take, post-operatively? Because dysphotopsias, they generally tend to resolve over time. positive dysphotopsias, they resolve over
Much earlier
time.
than negative ones.
Negative
Most-
dysphotopsias are symptomatic only in 2 to 3% of the cases. So
Yeah.
one needs to know, what is what was the type of dysphotopsia? Did he say he saw arcs, streaks, rings, halos, or did he say he saw dark areas? Usually negative dysphotopsia would be seen as dark areas in the temporal field.
Dr. Namrata, it was a positive dysphotopsia. He was complaining of glare and halos mostly.
Okay. Okay.
Yeah, streak of lights. Yes.
Okay.
And how was the response to brimonidine which he had used?
He was not very happy with brimonidine, and the dysphotopsia started 1 month after the surgery, and it still continued till the 7th post-operative month.
So just one point I wanted to add here is that the edge of this particular lens that does not have any refractive power in it,
Yeah.
and that is the edge that the patient is seeing. So it's just like how the Rexes, as Vivek has shown, is a little not covering that particular edge, which has no refractive correction on it. And also, Abhinav had an interesting idea, which has been described, that the placement of the haptics can be rotated from 12.6 to 3.9, and that is also another technique.
So for these cases, generally what happens is it is good to wait, no intervention, because neuroadaptation might occur, or you can exchange the IOL because it tends to occur more with the acrylic IOLs, which have a sharp edge as opposed to the smooth edge of the IOLs. And of course, if the IOL has high refractive index, then also it can occur. So another thing is that people have even done reverse optic capture, so that you raise the optic edge above the anterior capsule with the haptic in the bag. So that is also one option which can be done. And of course, neodymium YAG, not of the posterior capsule, but anterior capsulotomy of the nasal capsule can be done. So that can remove the reflection of the anterior capsulotomy edge on the nasal retina. So that has been done. People have gone to the extent that they have even truncated nasal optic truncations has been done, but I think that would be too severe. And of course, piggyback IOL can be done in the sulcus, which again I think would be too severe. So to my mind, if you have to do something, one can either do a reverse optic capture, or one can do a neodymium YAG anterior capsulotomy of the nasal capsule as a first line of management.
So
Can I add a
was a
point?
Tracy and study of the abrasion done for this patient?
So we had advice, the final visit, we had advice for the aberration, but could not get it done. So that is why I do not have the scans with us.
So
And much akin to the neodymium dysphotopsia ring, which has been described by Dr. Prakhyat Roop, who's now working as a senior resident with us, and he won an award also in EASCUS for that. Something like that, Vivek is also described. So I think third option could be also that.
So I think that we'll move on. Thank you very much, Vivek, for sharing this wonderful case. Thank you, Dr. Namrata. And
What did you do, Somshila? What did you do for this case?
Oh, the patient is waiting for. He was supposed to get operated. So some of the investigations are pending, but he didn't come back again. So we asked our colleague at the secondary center to start him again on either diluted pilocarpine or brimonidine and see how he does with that, because he's a driver by occupation, and so he's unable to drive. That's what he said. So he's going to use diluted pilocarpine and see how that works.
Somshila, I will just make a quick comment. I would measure the pupil diameter in the light, in the bright light and dark, and then try to see if it is the edge is a problem. Otherwise, just continue on conservative and explain. If still doesn't go away, then consider YAG. To me, the YAG probably might be the responsible, because once you measure the pupil size in dark, that will explain you what is happening.
All right. Very valuable information and comment, Dr. Sangwan. So with that, I'd like to hand over to my friend and colleague, Dr. Parikshit Gogate, for the next presenter. And Parikshit, there's a request for you to also introduce the discussants along with your introduction. Thank you.
Thank you, Dr. Somashila. Our next presenter is Dr. Prasad Vaimbe, pediatric ophthalmologist from Pune, who will be speaking on a case of ectopia lentis. And for the discussants, we have two stalwarts, Professor Namrata Sharma and Dr. Virendra Sangwan, sir. I would request Dr. Prasad to start sharing his slide. Dr. Prasad is a senior in BJ Medical College, and he has done his long-term fellowship in the Arvind Eye Hospital, Madurai. He was also one of the starters when AIDS had come. He has started an NGO for HIV people, and he also does a lot of rural work and community work. So over to you, Dr. Prasad.
Very good evening, respected chairpersons, moderators, case presenters, and learned viewers. Is my video visible?
Yeah.
Yes, it is.
Yeah, and am I audible?
Yeah.
Yes, you are.
Yeah, I am presenting a short video case of one of my surgeries in pediatric ectopia lentis cataract in a 13-year-old boy. Now, it was done almost 18 years back. What I would like to share with you all, what went wrong, how I managed this case, what was the reasons for, although brief, but unhappiness in patient as well as myself, what lessons I have learned, and what tips I would like to give so as to avoid such situations. Now, this is a 13-year-old boy from rural Maharashtra with bilateral ectopia lentis cataract. He presented with gradual diminution of vision over 4 to 5 years. The right eye was operated elsewhere. It had aphakia, postoperative complications, old untreated RD, and it was in pre-thysical condition. IOP was unrecordably low. This is the left eye, which it had ectopia lentis cataract. Corrected vision was 2/60 and 36 with oblique astigmatism, high myopic astigmatism. Intraocular pressure was 18 millimeters of mercury. Visible fundus through dilated pupils with indirect was grossly normal. Systemic workup by pediatrician was normal. There was no Marfan's, homocystinuria, or any other systemic condition. I was called upon to do this surgery by a respected and a senior ophthalmologist from this small town of rural Maharashtra. So let us start with the case. So now what went wrong and how I managed the case? Now some of you might agree with me that there are some OT days which are not yours. Everything goes against you. And the key is how you keep your calm and manage the case with your skill and experience. And that day was like this. The patient was intubated and I already started the surgery. Huge voltage fluctuations and load shedding was a norm in those days in rural Maharashtra. There was a huge voltage surge. In spite of having protective stabilizers attached to phaco as well as microscope, it just conked off. Phaco and attached vitrectomy couldn't be started in spite of brief efforts by the local rural technician. Now calling a phaco engineer from city was just out of question. And we didn't have the luxury of standby machines. Microscope bulb was fused, but fortunately there was a spare bulb. Now in panic, the assistant dropped the Rexis forceps from the trolley. And the running nurse dropped the only CTR which was available on the floor. And so the running nurse was trying to open it in haste and it dropped down. So I was left with an intubated one-eyed child, surgery in midway, a working microscope, basic cataract set, and a lot of anxious and panic faces around me in the OT. So let us see and how I tried to manage and do my best to salvage the situation. I tried to use the polypropylene haptic of the 3-piece IOL as a CTR and try to, salvage the situation. And since it was less than 5 clock hours of subluxation, so CONE ring was not there and only CTR was dropped down. This was a hydrophobic acrylic lens. I tried to use the haptic as a CTR. This is the edited video, but I took almost an hour to do the surgery that time. Postoperatively for almost 1 week, patient had high IOP, epithelial corneal edema, fibrin membrane, and anti-uveitis. Fortunately, it was managed conservatively with anti-glaucoma medications, cycloplegics, and steroids. The reason for unhappy patient was red eye pain, and poor vision for a couple of weeks, but fortunately was resolved in 2 weeks of time. And on top of it, the surgeon, the respected surgeon told the patient that a big doctor from Pune is going to come, you'll get a good vision. So I had to convince the child that yes, it will take some time. Now this patient is almost 31 years old. Now his vision is around 6.9 partial N6 with a minus 2.25 diopter at 50 degrees. There is no peripheral retinal degeneration. His two sons are also my patient. They don't have ectopia lentis, meaning that it was a simple case of simple ectopia lentis and not a systemic association. So retrospectively, when I think, I could have prevented this if I could have carried my own specific equipments like forceps, CTR with me. And the lessons I learned from the day are, no matter how big and respected center you are visiting for surgery, always carry your specific equipments and standby lenses with you. It has saved my day 3 times in the last 18 years after that. Whatever grim and dark situation you are facing, believe in yourself, keep your cool, trust your instincts and experience, and also always do your best. And also, however proficient you are in phaco, sometimes SIS always saves you. Thanks a lot for your kind attention.
I would request Professor Virendra Sangwan sir to give his comments.
I think the context what he described is in which he has performed is just brilliant, and there's not much to add because of his brilliant skill set and the, I think, mental balance. He could get the outcome which is exceptional in a given situation and circumstances that he was present. So I really don't have anything else to add, except that what he said, the tips, I think they are very helpful for people who visit different centers or different locations to carry some of the key things with yourself. Thank you.
Thank you, sir. Professor Namrata ma'am.
I think it was a great surgery considering that it was done, almost 18 years back, and the patient is still 6'6", N6, and 6'9", N6, and doesn't have any problem and is still going along. I did see that there was ectopia lentis there. The only thing is that probably, from what I could gather, the haptic, the 3-piece lens that you have used, the haptic of that lens has acted like a I shouldn't say like a CTR, but that has helped to, expand the bag. But in all such situations, even if you use a CTR with that kind of ectopia lentis, you would probably need to suture the bag to stabilize the bag. But so far, so good. The patient is doing well. And I think it was a great, clever thing to do that, you did SICS instead of trying to venture into phaco or thinking that we'll do it at a later date.
Yeah.
Very nice.
I think this presentation was more of an unhappy and surgeon and unhappy patient in the initial phase of the surgery. And afterwards, it's a happy ending. Both the surgeon and the patient both are happy. Right, Prasad?
Yeah, but I was still not happy. I could have prevented that if I could have carried. But after that, in fact, I have carried all the equipments I used to carry, wherever I'm visiting. And it has saved me my day 3 times after that.
So this presentation shows to the audience that you should not lose your cool, and you should be prepared with an alternative plan whenever you have such hazards occurring in between the surgeries.
And perhaps instead of the surgeon traveling to a remote place, the patient from the remote place should travel to the surgeon, where the surgeon is most comfortable and has all the equipment available.
Yeah, but there are some different sets of problems in rural thing, because many of them are, the wards of daily wage laborers. They can't afford to come to the city. So the problems in city are different from problems in the rural area. So many of them, otherwise they don't come.
True. No, having done a clean case definitely helps. Yes. I mean, without doubt.
Very nice surgery, Dr. Prasad.
Thank you, sir.
I think
we can move on to the next presenter. Thank you, Dr. Prasad. Dr. Prasad is also a prolific teacher for undergraduates and postgraduates which he does in spite of his busy private practice.
Thank you, Parikshit, for the kind words.
Yeah. Dr. Prathma, you can start your screen sharing. Yeah. Now, I'll introduce the next speaker, Dr. Prathma Sarkar. She did her graduation from Maulana Azad Medical College, Delhi, and then her post-graduation MS Ophthalmology from University College of Medical Sciences, again from Delhi in 2018. She has also passed her DNB in 2019, and currently she's working as senior resident in my institute. She has published in many journals and is a prolific presenter at state and national levels, and she is actively involved in organizing clinical meets at our institution. So Dr. Prathma Sarkar will be presenting on unhappy patient of a cataract surgery in eye with previous glaucoma surgery, and the lead discussants for her presentation are Dr. Pradeep Vyas sir and Dr. Sunil Morikar. Dr. Prathma, screen is all yours. Over to you. Start your screen sharing.
Good evening, everyone. Thank you, Bhala sir, for the introduction. I would like to thank the AIOS Scientific Committee to give me the opportunity to present my case on the unhappy patient of cataract surgery in the eye with previous glaucoma surgery. So a 48-year-old male presented to the OPD with the chief complaint of diminution of the vision in the right eye for past 2 months, which was associated with a constant dull aching pain in the same eye. There were no associated complaints. He had a history of COPD and was putting brimonidine eye drops and brinzolamide eye drops thrice a day in the other eye, that is the left eye. He had undergone glaucoma filtration surgery 1.5 years back elsewhere. Post-filtration surgery, after 4 to 5 months, he noticed gradual progressive painless diminution of the vision in the same eye and was diagnosed with grade 3 cataract. The patient was taken up for the cataract surgery there itself. The patient was doing well until 2 months back, he started having further deterioration of the vision and constant pain in the right eye. On examination of the right eye, his BCVA was 612, and in the right eye, in the left eye, it was 6/9. The IOP recorded was 25 mm of mercury on no anti-glaucoma treatment on the right eye. In the left eye, it was 18 mm of Hg. On slit lamp examination, there was a flat bleb with excessive vascularity over the surface. The fundus examination showed a deep cup of 0.8 to 0.9:1 cupping with an NRR thinning and a bipolar notching. In the left eye, there was a circular disc with deep cup of 0.7:1 with NRR thinning. The RNFL findings and the visual field analysis were corresponding with the same. On gonioscopy, the right eye had an open internal sclerostomy in the area of trabeculectomy. The left eye had open angles. Then we started the patient on tab acetazolamide 250 mg 4 times a day, along with brinzolamide and brimonidine eye drops thrice a day. However, despite giving this treatment, his IOP recorded was still between 17 to 20 mm of Hg, which was a little far away from our targeted IOP. So when we did the ASOCT of the patient, we could see the patent and low reflective inner cavity with a thick and hyper-reflective bleb wall, which was suggestive of a moderate to poorly functioning bleb in this case. So we took up the patient for needling, which was done with a combination of mitomycin C 0.01 ml and bupivacaine. Post-operatively, he was started on hydroprednisolone acetate 8 times a day, along with hydromoxyfloxacin 4 times a day. On the 10th day of the slit lamp examination, we saw an elevated functional bleb, with the IOP recorded now being between 12 to 15 mm of Hg. He was continued on hydroprednisolone acetate 1% 4 times a day. The patient has been now asked to follow up on a regular basis. This being the case, our question was, why was the patient unhappy? So according to the patient, the consent of the surgery was not made understood to the patient properly. The outcomes of the surgery were not told to him properly. He was unhappy being called again and again for the frequent follow-up, and more so ever in this COVID times. He was concerned about the decreasing visual prognosis, and being a young male, he was concerned about his cosmesis. So if we just rewind a little bit and ponder what led to the bleb failure, or what could have been done intraoperatively to prevent it, the first question that comes to our mind is, what's the cataract surgery really required in this case? So we have all pros and cons for it. For the positive side, people say yes, if it is on a greater side, the cataract on a higher grade, go for it so that a posterior segment evaluation can be better in these patients. And moreover, for giving them an improved quality of life, you can go for the surgery. However, more of the studies have shown that there is an increased risk of bleb failure in these cases, as much as 33%. So what all pre-op causes could have been taken into consideration to prevent this? The first is the timing of the surgery. More the interval between the two surgeries, the greater is the chances of the bleb survival. So the studies have shown that a gap of 1 to 2 years is sufficient to protect against the bleb failure. In our case, the gap was hardly of 6 months. And secondly, we should check that the IOP before the cataract surgery, if it was on a higher side, and number of anti-glaucoma drugs the patient was taking, because both of them are also directly corresponding to the greater risk of the bleb failure. And we should also assess the functionality of the bleb beforehand as well. Next was the age of the patient. Younger the patient, greater are the chances of fibrosis, and thus greater are the chances of the bleb failure. Our patient was on the younger side. The site of incision should be the area of the should be avoided, or the area of the bleb should be avoided. In our case, there was a temporal clear corneal incision being given. So in the post-op period, what could have been done? These patients have low-grade subclinical inflammation persisting in the eye for over 6 months, along with the spike in the IOP in the early post-op period and major fluctuations seen in the first month. Therefore, it's very much recommended that these patients should be given an aggressive amount of anti-inflammation drugs or steroids for a longer period of time. Our patient discontinued the steroid drops on his own after 1.5 months itself. So what steps could have been taken intraoperatively to take care of this patient? Ideally, we should go for a topical anesthesia. If not possible and going for a peribulbar block, try avoiding the massage. Then proper handling of the eye should be there. Try using wire speculum. The clear site corneal incision should be away from the site of trabeculectomy. Do the least amount of iris manipulation possible. Take proper care of endothelium. Use dispersive viscoelastics. Maintain the active fluidics. Try keeping the vacuum setting on the lower side. Try removing the nucleus removal should be done in the capsular bag using the hyperburst mode or the hyperpulse mode. And a thorough removal of the cortical matter should be tried to be done. Try placing the IOL in the bag. Try avoiding AC IOLs and multifocal IOLs. Do a thorough AC wash to remove the viscoelastic and ensure a watertight closure of the wound. And at the end of the surgery, do try assessing the bleb. And if any revision is needed, kindly do the needling or adding of any kind of antimetabolites if needed. So how to make the patient happy in this case? From the aesthetic point of view, try to be patient with the patient and answer all his queries. Try to counsel the patient. Try to explain him the longer period of follow-up that is required. And from the surgical point of view, proper pre-op evaluation should be there. Utmost care of the intra-op steps should be taken. The bleb assessment should be done at the end of the surgery. And finally, vigorous post-op management of the inflammation should have been there. And for at the end, as doctors or as ophthalmologists, we should try to under-promise the patient and over-deliver the patient. Thank you.
I think the case is open for discussion. I would invite the lead discussants, Dr. Pradeep Vyasar, who is a senior consultant at Center for Sight Indore, and Dr. Sunil Morekar, who is President, International Society of Oculoplasty and Reconstructive Surgeons, and is presently a consultant at Kambala Hill Hospital at Kem's Corner, Mumbai. Dr. Pradeep Vyasar.
Yeah, thank you, Dr. Bhalla and Scientific Committee. Dr. Prathama has explained everything about that. You know, why the patient is unhappy and what done, and she has done most of the things. See, the biggest problem what I see in this patient is a young patient, just 48 years old, and has a very advanced glaucoma in one eye. The other eye is almost normal. Why he has such advanced glaucoma that she did not tell. He might be having a traumatic glaucoma or some form of secondary glaucoma. But if the patient is young, having almost normal visual field, normal vision in one eye, and having such an advanced glaucoma in the other eye, and likely to undergo second surgery soon after the first surgery, that is an anti-glaucoma surgery, always you cannot make that patient very happy. Because, you know, if you give a 6/6 vision or 6/9 vision, with such a reduced field, the patient will never be comfortable. Because you have given the quantity of the vision, but the quality of vision is very poor in this patient. And the young patient always realize that. So the biggest thing for these patients is the counseling. Counseling is must. You must do the thorough counseling before taking the patient for the second surgery. You must explain to the patient that, you know, we are trying our best to conserve the vision and conserve the field of the vision, but the patient has a significant longevity. He may live for another 30 to 40 years. Until that time, to maintain that much of visual field following 2 surgery is a very difficult task. The patient has started showing the increased IOP, and sooner or later, in spite of this needling, though the needling has worked for a short duration, in spite of the needling, this patient would require another anti-glaucoma surgery. And in spite of doing another anti-glaucoma surgery, obviously that will be AGV, still the patient has a risk of losing the vision. So that always the patient must know and the treating doctor must know. And these are the patients who keep on hopping from one doctor to another doctor, and what the other doctor is telling you never know. So you must assure the patient that you are trying your best, but still patient should understand that he may lose that very little bit of vision whatsoever is left, maybe in the near future or distant future.
Dr. Sunil Borekar, sir.
There are a couple of things that I would like to add here. From my perspective, since I work in multi-specialty hospitals and we look at the eye in terms of systemic disease, what I would see and the other aspects that we talk about in terms of the ethics and the attitudes. This is a 48-year-old and I'm 48, so I would put myself in his shoes and try to figure out what he would be thinking and what he would be expecting and what he would be um, uh, worried about most. Now, as far as I think here, the most important thing in terms of medical legal issues would be the proper counseling. Now, you have a patient who's 48, you have to look at the systemic conditions. One of the important things that you had underlined there was chronic COPD. So that is something that you look at. I mean, I also happen to be somewhere around 48. I also happen to be COPD. So I know that there are times when you are generally inflamed as a systemic condition. So there is systemic inflammation in your body, and that is something that you need to look at pre-operatively. So whenever somebody is doing a cataract surgery or somebody is doing any surgery, you need to look at the systemic condition in terms of you may not always have an ESR raised, you may not have any signals that tell you that the body is systemically inflamed or near inflammation or at the edge of inflammation, and you doing the surgery will push this patient into inflammation. So that is something that you need to look at. That is one thing. The second thing is that when you look at the bleb, and whenever you're doing a cataract surgery in a person who already has a bleb, an evaluation of the bleb, as far as I am concerned, I end up doing an ASOCT for the bleb pre-operatively and post-operatively again, because a pre-operative bleb evaluation is something that would give you vital clues as to what is happening inside the body. The third thing is that you rightly pointed out, there are a lot of things you have very rightly pointed out, and I don't think there's much we can add here. But just for the sake of all the audience to emphasize on these particular points, there is something called as sympathetic ophthalmitis we talk about in trauma, in oculoplasty. But if you were to really look at the anterior chamber and the aqueous you collect when you're doing the other eye, when you operated one eye and you operate the other eye for a cataract surgery, you take the aqueous from that, and I have done this myself, and you send it for inflammatory markers. You'll be surprised to see that patients may have inflammatory markers in the other eye. So even after a cataract surgery, there is something called a sympathizing eye. So you will find inflammatory markers in the other eye up to 6 weeks after a cataract surgery, after an uneventful cataract surgery in a patient who has got no systemic problems. So when you're doing things in a COPD or in a person who has other issues, you would want to understand that you want to delay the surgery, a second surgery, as much as possible, because that would in fact mean that you will have a bit of an inflammation. And for a bleb, inflammation is near fatal. If you have any inflammation, your bleb is definitely going to fail. So these are the three things that I would keep in mind. And the fourth thing is medical legally, the consent. And in terms of COVID, you have to understand one thing, that whatever we have seen during COVID in all the hospitals across Bombay, we have seen that any pre-existing inflammatory disorder that you had an RA, we had patients who were controlled with RA with an RA factor of 10 or 15 or something like that. They've come with RA factor of 1000. You have patients who have myasthenia gravis, they come with an excessive amount of myasthenia antibodies. You have thyroid eye disease and they come with huge amount of anti-TPO antibodies. So somehow in this COVID era, we also have to keep in mind that whatever is my pre-existing inflammatory disorder might be accentuated, I'm not saying will, might be accentuated. And this is something that has to be there in the consent, And whenever we are treating a patient who we are going to operate a second time, we need to tell this. And the other thing is that somebody has come to me from some other place, we have to handle it, and we don't tell them that somebody made a mistake. So we don't want to badmouth our colleagues. But at the same time, we have to keep in mind that this is something that is going to come up. And in a very nice way, we have to tell the patient that we are expecting inflammation, and this is known to happen. So you make sure that you protect your colleague by telling them that this is something which is known to happen. This is not that somebody has done as a mistake. This is not that somebody should have not done it or something like that. But here, given this situation presently, we will be worried about inflammation, and we know that the blebs might fail. The last thing is you need to look at carotid Dopplers, because even as a 48-year-old, I have bad carotids and there are plaques in my carotid. So a carotid Doppler in an unequal disease is something that I would always look at. These are my points as far as my experience is concerned.
I think very nicely explained, sir.
Balasab, quickly.
Yeah.
Prathama,
Please.
what was the primary cause for unhappiness in this patient?
So first of all, he did not know that he have to follow up again and again. And since it was a
second
COVID,
cause? Frequent follow-ups is one.
Since it was a COVID time, he was more apprehensive of following up. And secondly, he was in this notion that after 2 surgeries, he did not have to put any kind of eye drops. So he was worried why after 2 surgeries also he's needing to put eye drops. So that was his other concern. And third, he being a young patient was very much disappointed with his decreasing vision and the cosmesis, obviously.
So all these 4 factors you couldn't have avoided, whatever technique you use. COVID you can't avoid, frequent follow-ups in a glaucoma patient you can't avoid. Poor vision, you can't restore the field of vision, whatever is there.
Counseling.
I think it's,
it's just proper counseling with the information of further course of event, which can be possible in these type of cases if would have been explained to the patient beforehand that there is a post-filtering bleb, we are going to go to a cataract surgery, the bleb might fail, you might need a frequent follow-up. I mean, all this proper counseling with the course of further events, possibility of further events, if would have been explained to the patient, he wouldn't have been unhappy.
Exactly. Very nicely said, Dr. Amit. And probably, particularly when the surgery, both the surgeries had been done at some other center and the patient was not able to follow up because of COVID and he landed up at our place. One thing I would still, I think it's difficult for me to understand is probably the cataract surgery. Probably, although the treating surgeon was the best judge, but the cataract surgery maybe could have been delayed much later, because as it was from his record, the uncorrected vision was 624. So cataract surgery, if it could have been delayed, maybe the inflammation was less and the bleb failure chances could have been reduced. And
sir, bleb failure was not, sir, again, we miss here. Again, one colleague going on to the other colleague will happen if we talk of that, because we should respect the cataract surgeon's decision. That is final.
Agreed.
Then he would say in the first instance, it should have been done a combined surgery. You know, all those things will come up, but that is not the primary cause of his unhappiness.
No, it was not the primary cause. We are just discussing technical points.
No, sir. Then again, we will miss the bus. We will miss the bus because
if cataract surgery has my point is, sir, if cataract surgery has been to be done in a patient with the pre-existing filtering bleb, then what is the ideal time? How long should we wait? Should we wait for 3 months, 6 months, 1 year? What is the ideal time?
Even if you wait 5 years, it can fail, sir.
It can fail. That's
bleb can fail. You do after a month, it need not have to fail. See, it's such a variable thing, So, and hence, that is not the primary cause for his unhappiness. He is saying multiple times, COVID time, poor vision, even if you wait for 2 years, you can't restore his. As professionals, we should respect other professionals' decision to.
Very true, sir.
This thing. And here, probably after he has come back with this, the first question resident would have asked is, did they not tell you about coming back again, or some kind of questions like this? Why was it done so early? That will increase his unhappiness. One surgery has been done, another surgery has been done.
This is not for the patient, sir. What we are discussing is the literature says 1 year is the ideal period depending on the grade of the cataract. Any surgery done before 1 year, there are chances of failure of the bleb increases, although it may increase even later if you do after 1 year. But 1 year, the literature mentions is the ideal period. Less than 1 year, chances of subclinical inflammation and the bleb failure chances are much more. This is only for our academic discussion, sir.
You're right. Weiler, I think we'll stop this discussion over here.
Yeah. Just last point, Amit.
Yeah.
Just last point, Amit. I agree with Dr. Bhalla. Ideally, we must give 18 months time to do a cataract surgery if possible. And number two, always remember that there is always an increase of IOP of around 3 to 4 millimeter of mercury following the second surgery, that is a cataract surgery. So that is the point I would like to highlight.
Thank you, Dr. Vyas. So now we go to our next presenter. So just a gentle reminder to all our speakers and our judges, we have 4 minutes for our presentation. Admin Sunil is there. He will give the first reminder at the end of 3 minutes and the last reminder at the end of 4 minutes for the presentation. And we'll limit our discussion for 6 minutes so that everybody gets an equal chance for his case to be answered properly. So my next speaker is Dr. Shweta Tripathi. She's done her MBBS from BRD Medical College, Gorakhpur, and DNB from Pondicherry Institute of Medical Sciences, Pondicherry. She's done a glaucoma fellowship from Shankar Nethralaya. She was the organizing secretary for the National Conference of Glaucoma Society of India at Lucknow in 2019. She has many publications to her credit in national and international journals. So over to you, Shweta. Request you to start sharing your screen. And Sunil, request you to please time up our presentations. Sunil, are you there?
Yes, sir, will do, sir.
Yeah, so will you please time up the presentation so that everybody gets an equal opportunity for the case to be discussed.
Yeah, thank you, Dr. Amit. So not wasting much of time as we have to be in time. So I'm just starting my presentation. A very good evening to all. And I would like to thank all the office bearers and the esteemed dignitaries of AIOS who have given me this opportunity. So this was a platform where I was to share one unhappy patient, but since I have a series of unhappy patients who were unhappy because of a common reason related to the medical management of glaucoma, I would be sharing 3 of such cases. So this was a case of a 65-year-old gentleman who presented to me because all these unhappy patients were not initially treated by me. I was the secondary doctor who was treating them. So but I would like to share all these cases here. So this was a case of 65-year-old gentleman who presented to us, who was being treated for conjunctivitis with oral steroids, antibiotics, and the glaucoma was well under control with the treatment of a combination therapy of a beta blocker and alpha agonist inhibitor. The cause of unhappiness for this case, as we can make out from the pictures itself, is that he was pain, burning, watering, and the most important point was that there was a difficult blinking also for him. So the patient was made happy through us by first of all, stopping all the medications, whether it was oral or topical, and identifying the cause of unhappiness, which was a alpha agonist allergy. So immediately that was replaced by the combination of beta blocker and a carbonic anhydrase inhibitors. Also, along with that, the patient was given a low dose steroid with antibiotic topically with the oral antihistaminics and cold fermentation. Coming to the second case for tonight, that this was a 65-year-old gentleman again who was on treatment with PG analog and was quite happy with the control of his glaucoma, till he came to us with his unhappiness, the cause being the cosmetic disfigurement, which was coming out in the form of hypertrichotic lashes. That's because the patient was being treated in single eye. That was the single eye, one eye, which was getting treated with the PG analog. So immediately the patient was made happy by stopping the PG analogs. And the lesson learned here was that the unilateral initiation of a PG analog therapy should always be used with caution. Third case, this was very important in the time of pandemics. This was a case of a 70-year-old gentleman who had a BCVA of 636 and 160 in right and left eye respectively. The Goldman applanation tonometries were in the range of 30s. March, the pressures were controlled and he with the maximum medical therapy, and he was advised surgery till the pandemic set on. So we lost to follow up this case. And then October, when he presented to us, to our uttermost dismay, he was having deteriorated vision in the right and the left respectively, with the pressures shooting up. The cause of unhappiness, needless to say, was profound loss of vision in both eyes. What we tried to make the patient happy was by a proper counseling and just making the aggressive treatment by halting the disease progression further. And the lesson learned here was a proper adherence and a proper persistent patient with a proper counseling and a teleophthalmology, which is coming to role, which is playing an important role these days for the patient who cannot come physically to the clinics. They can take advice over the teleophthalmology instead of discontinuing the AGMs on their own. So there are three important points which I would like to highlight here. Why the above patients were unhappy, and was there anything which we could do to make them happy? Do we commonly see such cases in our practice? And the answer to all of them comes out to be yes. So there are certain challenges when we are sitting in a glaucoma clinics. That first is, when we talk about glaucoma disease diagnosis, the first thing is that identifying and treating the correct cases so that the drug overload can be prevented in the eyes where it is not needed. Like the top picture which I have shared is, that's a simple physiological cupping. Simply, it may be said that not all the 0.7 cuppings are a glaucomatous cupping. We have to comment on the NRR, the health of the NRR, before we say that, okay, this is a 0.7 cupping, we should put the patient to the anti-glaucoma medication. Talking about the pragmatic approach of the glaucoma medical management, that is
4
stepping
minutes
up
are up.
or stepping down the treatment. When we talk about the common, these two case scenarios, who were having a common baseline IOP, that is 26 millimeters, the left-sided patient definitely needs a little higher target IOP, lesser number of drugs, and a lesser number of side effects which are related to the anti-glaucoma medications. The awareness about the side effects of AGMs are really required, and we all should be alert, because none of us wants any of our patient's eye to suffer like this. And the road to the happy patient is definitely going to be by proper detection, strategy planning, and following up with reassurance. Thank you.
Thank you, Shweta. So we have our lead discussions for this case of yours. We have Dr. Pradeep Vyas and Dr. Vayal Rajshekhar. So I would invite Dr. Pradeep Vyas to open up the discussion.
Yeah, as Dr. Shweta pointed out, every single anti-glaucoma medication has its own side effect. And what I have seen in my practice is that the most safest and most tolerable anti-glaucoma medication is a beta blocker. But the beta blocker, all of us knows that is almost contraindicated in our 40% of the patients. So all remaining anti-glaucoma medication, be it the alpha-2 agonist, be it the PG analog, be it the carbonic anhydrase inhibitor, they all have their own problems. And almost 30% of the patients, they are not able to tolerate the first run. And you have to explain to each and every patient of yours that what are the probable side effects of each of these medication the patient may likely to face in the future. So once the patient is comfortable and happy, then he would remain happy and comfortable. But otherwise, there are many occasions where you have to change the medication and you have to switch the patient to another medication. And there are quite a few occasions where the patient is not able to tolerate even a single medication. But yes, over a period of time, if suppose the patient starts the PG analog, then hypertrichosis and periorbital, the prostaglandin-induced periorbitalopathy would not develop immediately. It would take pretty long time. Till that time, the patient will be happy. But again, over a period of time, the patient would become unhappy with the medication. And then if you change the medication, then probably alpha-2 induced toxicity would go away. But the PG analog induced periorbitalopathy would not go away so shortly. So always explain to the patient that there are some changes related to medication which may persist for a very long time or maybe lifelong, but the patient has to put the medication, and we are giving this medication to save his life.
Dr. Vayal
Perfectly
Rajshekhar.
fine. Perfectly fine. Yeah, I totally agree with Dr. Prateek. It's more of a challenge that each glaucoma surgeon faces because of the limitation of the drugs. Each drug comes with its actions and equally effective and more commonly seen side effects. Educating them and taking them along is an important thing. Many times what I have seen is while we prescribe medicines, we speak about their benefits. I think in anti-glaucoma medications, we should also say the expected, the possible side effects, because patient, once they start developing redness or some other symptom, they may think that it's an aggravation of the disease itself or a new disease that has come. And when they come back, if the doctor opens up a discussion saying it could be due to the medicine, then, they're not totally convinced kind of a thing. So if you have said these are the kind of expected things, then probably that will help. It's a challenge, actually. It's a challenge and probably good patient education and taking them along. And another important point you said is starting treatment. You should be 200% sure before deciding on the treatment, because another challenge that comes is starting treatment is easy. To stop a treatment in a patient who has been on anti-glaucoma medication for a physiological cup or query illness is more challenging, because one who stops the treatment will be blamed later in case should things go the other way. So that's well pointed out.
Dr.
It's a
Girish,
challenge.
you have a comment to make?
Yeah, thank you. I think Dr. Shweta very well presented unhappy scenarios. You have touched upon an important topic, that's the teleophthalmology. And I'd like to just highlight the difference between a teleconsultation and a telecounseling. I think that's very important for us to understand so that we make the patients happy. What we can really do now on most of the situations is only a telecounseling, where we talk to the patient and listen to the symptoms and maybe just try and counsel them to either continue the medication or seek another appointment. The real challenge would be for us to actually have a teleconsultation, where we could actually, have some gadgets, home devices where the patient can have an eye checkup done, or even send a slit lamp photograph of the anterior segment or even the posterior segment. And even today in the BRSI, we had a nice talk on the upcoming home OCT managed device for patients with AMD. I think that would be the next challenge for us, to graduate from the telecounseling to the teleconsultation. That's all I had to comment. Thank you.
So Shweta, the nutshell for all the presentations till now, what has been made, it's the chair time and the proper counseling and information giving, which if a doctor does properly, 90% of the time our patients won't be unhappy. So the key to a happy patient is giving a proper chair time with proper information about the disease or the surgery which we are going to do. So now I invite Dr. Sonu Goyal, our next scientific committee member, to start with the next presentation. Sonu, over to you.
So thank you, Amit. Am I audible?
Yeah, you're audible, Sonu.
So let me introduce the next speaker, Dr. Sonaya Mukherjee, and she'll be talking on From Tears to Smile, the multifocal IOL. And the lead discussion for this talk would be Dr. Virendra Sagwan and Dr. Namrata Sharma. Dr. Mukherjee did her fellowship in phaco-refractive. She is a consultant at the Anand Eye Hospital, phaco-refractive UV and comprehensive ophthalmology in Jaipur, Rajasthan, an NB accredited postgraduate teacher, a member of ESCRS, APACRS, has a lot of publications, indexed and non-indexed, and has won APO Achievement Awards and free papers and posters in various national and international conferences. She's an active member of the scientific team for Rajasthan Ophthalmological Society. So all to you, Dr. Mukherjee, you can start sharing your screen now.
Thank you so much, Dr. Sonu sir, for giving me this opportunity. Very good evening, respected chairpersons, and all the speakers and the moderators. So I've been talking about the unhappy patient. So my unhappy patient from Tears to Smile is a multifocal lady. As we know that this is an era of quality of vision, and this is a new era of expectations, and we all have 2020 unhappy patients, and 2020 unhappy patient is not acceptable to all of us. So my patient comes frowning to my OPD, and she's a 52-year-old lady. She has undergone a right eye phacoemulsification with a multifocal IOL, which is an Alcon restore, around 8 weeks back elsewhere in a metropolitan city. And she constantly complains of diminution of vision. She's not happy with her distance vision nor with her near vision. She constantly complains of dysphotopsia-like features. She's not willing to wear any kind of glasses, and she doesn't want to get the other eye cataract operated at all. She doesn't want us to touch the other eye. So let's now open the mystery. So let's see what we have to unfold. First of all, her visual acuity is uncorrected 624. With pinhole, she is 6/6. So at least we know that inside the eye, there is nothing abnormal. Her refractive correction, she has an induced myopia with induced astigmatism. She's undergone an ND-YAG laser capsulotomy around 4 weeks back in the same center. And she had an OCT report, which was normal. We did a dilated fundus examination, did a periphery to rule out any more retinal pathologies, which was absolutely normal. So next, very important, a dilated slit lamp examination. We suspected it is a tilted IOL, a tilted lens. So as we all know, a post-operative refractive surprise after cataract, you have to do an IOL power calculation, rule out any miscalculation in the lens power. So she had a restore lens card, which was showing a power of +21. We did an IOL master 700, which was showing 21.5. It's absolutely fine. So we have to rule out any ocular surface abnormalities. Her cornea looks normal. Her topography, her pentagam was absolutely normal. So then we did a night ray-C. So in a night ray-C, what we do is we have to check for centration or tilt. So there is a radial ruler which overlays the IOL, which will provide us a centration information. And if it is a non-circular, if the IOL is non-circular, it might be tilted. So in a tilted lens, the map is always from colder colors to warmer colors. So one side there is a cold color and the other side is a warm color. So this is a paper analysis of this patient. You can see that the higher order aberrations of the internal optics is relatively high, which shows that it is a tilted lens. So now we have to unfold the mystery more. So we take her in the OR and we see why the lens is tilted, and we have to reposition this lens. So we did a repositioning of the lens. So first of all, as we all know, we have to first counsel the patient. We take the patient inside the OR, make 2 sideboards. As you can see that in the center, there is an opening which has been made by a YAG capsulotomy. We put enough amount of OBD, a viscoelastic. And then with the right hand, I use a dialer and I try to nudge the lens, and I pick the lens, the optic, and suddenly I find that the superior haptic is folded reverse. So this haptic, which should have been the opposite side, it is reverse folded. So what I do is I use another dialer with my left hand and I turn it around and I turn it in the exact position. So both the haptics were in the bag. The only thing was the superior haptic was reverse folded. That's the reason it was nudging the lens and causing a tilting of the lens. After this, I do an irrigation aspiration. I wash the OVD properly. And you can see the lens is well centered. You can see the Myers in the center. So hence, my patient was from unhappy to happy. She left our OPD with congratulating us with a vision of 6/6 and N6. And she also went for the other eye cataract surgery with the same lens. Thank you so much. And thank you for allowing me to present, and thank you for listening.
Thank you, Dr. Mukherjee. And the lead discussants would be Dr. Sangwan and Dr. Namrata Sharma, ma'am. Yes, Dr. Namrata, ma'am.
I think it was a very nice presentation. Done very well. Only thing is that from what I could gather, the surgery was done 8 weeks ago, Sonali.
Yes, ma'am.
And then somebody's done a YAG also
YAG around 4
within the
weeks.
next 8 weeks, and there was quite a lot of PCO, which has,
Ma'am, that
occurred
could be because of the IOL tilting that could
yeah.
have been so much of PCO formation within a period of maybe 6 weeks.
Yeah, that's because there's not enough, this gap between the IOL and the PC is a lot more than desired. The IOL is not stuck to the, back of the PC as one would desire. And that is why cells have migrated there, and it has led to this. So I think a very nicely managed case and very nicely shown problem. This is a rare thing, and this you'll only come to know after you deal with it, after you try to tackle a lens which is tilted, and also talks volumes about the technology ITRIS, which picked up the tilt and helped you to arrive at a conclusion. So this has a very informative and educational case, I should say.
Thank you, ma'am.
Dr.
Yeah, just Dr. Mukherjee, was this when you dilated the patient preoperatively, the kinking of the haptic was visible or not visible?
No, sir. Actually, the kinking was not visible, but the lens was also was looking a bit tilted, but we could not see whether it was on the other side, because could be she was not fully dilated that much, because we were not able to see the other superior part. It was a superior haptic, sir.
Very, very nicely presented and very well managed. Thank you and congratulations.
Thank you, sir.
So I would now request Dr. Bhalla.
Yeah, I would now invite Dr. Srini Edlekhon to present her case on post-op unhappy patient with strange complaints. And the lead discussants for case of Dr. Srini are Dr. Girish Rao and Dr. Y.L. Rajshekhar. Dr. Srini, you can start your presentation.
Srini, you are not audible.
You are muted.
Sunil, can you please check?
No, I think Srini is now not muted.
No, he's not muted. He's having some problem with the audio, I think. Sunil?
Can you
Yeah.
help us out?
So audio is not coming. Everything is showing green from this side.
So maybe, meanwhile, we can take the next presenter. Meanwhile, we
Yeah,
can.
I think KP is there. Dr. Krishna Prasad?
Srini, if you have headphones, disconnect that.
No, there are no
You have
headphones.
headphones,
I think the mic is a
I
problem.
think he's getting it solved. We can just wait.
Yeah, till he gets it solved, we can start with the next presentation. After Krishna Prasad finishes his moderation, we can get back to Dr. Balla. Till that Srini can cover up itself. So Dr. Krishna Prasad, over to you.
Yeah, thank you, Amit. I think it's my pleasure to introduce my friend, Dr. Sunil Ganikal from Davangere. He's a director of Davangere Nethralaya. He is, I can say, one of the pan-ophthalmologists. I think he has done his Vitreretina fellowship from prestigious Shankar Nethralaya, followed by then he was working in MM Joshi Hospital. Then later on, he started his own hospital called Davangere Nethralaya. Apart from his Vitreretina surgery, I think he is a very good clinician, past scientific committee chairman, Karnataka Ophthalmic Society, also joint secretary of Karnataka Ophthalmic Society. So he'll be talking about some interesting case you've been telling me. I think over to you, Dr. Sunil Ganikal.
Thank you, KP. Thank you for, hope I'm audible. Am I audible?
Yeah.
Yeah. Thank you, KP, for the kind introduction. Let me share my screen. Okay, today I'll be presenting two short cases within a stipulated time. Both have got the same post-operative problem, but we have treated them differently. The first case is a 60-year-old woman who underwent a phaco-foldable IOL implantation 9 months back. She had a good post-operative visual recovery of 6/6, but came back to us with a decreased vision in the right eye, in the operated eye. After 2 months, the vision dropped to 6/24, but it was improving partially up to 6/9 parts. To our surprise, the refraction, post-operative refraction, showed an hyperopic shift of plus 1.5 diopters. That was the matter of concern. There was a late post-operative refractive surprise in an uneventful phaco. The IOP was normal. Slit lamp examination was unremarkable. Cornea was clear, but the only positive finding was there was a slight increase in the anterior chamber depth. There was no pseudophacodonesis. After dilatation, we saw a slit lamp examination. You can see in the clinical photograph on the left side, you can see a anterior capsular contraction with markedly thickened peripheral anterior capsule, but the IOL remained stable in the capsular bag. But on the right side of the clinical photograph, you can see that the anterior chamber is deepened, and yellow line shows the position of the IOL. You can see the slight posterior vaulting. The fundus examination was normal in both the eyes. Considering this scenario and hyperopic shift, we thought it could be due to the contracted capsule, anterior capsule. We thought of doing a non-invasive laser anterior capsulotomy was planned in this patient. Symmetrical 4 radial cuts were given, as shown by the yellow arrowheads. The ag laser was applied from the capsular margin up to the just short of the margin of the optic, and the incisions of the IOL over the haptics were avoided because if you do a ag laser over the haptics, it can cause an asymmetrical lens tilting. So 1 month after ag laser, you can see the post-operatively on the right side, post-treatment, the anterior chamber depth came back to the normal position. Even the thickness, the anterior chamber depth was normal, and the lens position also, effective lens position also moved it to the immediate post-operative period. So the spherical equivalent reduced, that means to say hyperopic shift is reduced. Even this was stable for 6 months of post follow-up. So I would like to highlight here that the simple ND-AG laser anterior capsulotomy is a safe and effective procedure for treating capsular contraction syndrome associated with hyperopic shift, which could be due to the posterior IOL vault. Let me move on to my second case, which has got a similar problem but managed in a different way. Here is a 50-year-old male who is a diabetic and hypertensive for the past 10 years. And he had undergone a PRP laser for his proliferative diabetic retinopathy. First, he visited us in the March 2018. On right eye examination, he had a 636 vision with a posterior subcapsular cataract. Fundus examination revealed a lasered PDR, but there was a TRD, but it was extramacular and a focal TRD. On the left eye, there was a 612 vision, best corrected visual acuity with an early PSC, and the fundus show a lasered stable proliferative diabetic retinopathy. Was advised a phacoemulsification surgery in the right eye and a periodic eye checkup of the left eye, but the patient was lost to follow-up. but came back to us after in the recent couple of months back in June with a persistent decreased vision in the right eye for the past 4 months. He gave a history that he had undergone a phacoemulsification with foldable IOL done elsewhere 1 year back. And now he says that he has got a decreased vision in that eye, and his main now cause for the unhappiness is decreased vision in spite of a good phaco done. He attributed the vision loss to the poor quality of the IOL, and he wanted his IOL to be replaced or exchanged. And he asked me, is the surgeon at fault or the IOL is at fault? Then we started counseling him, and on further examination in June 2020, he had a best corrected visual acuity of right eye of perception of light. Left eye, he had a 636 vision due to the significant cataract. Anterior segment examination of the right eye, you can see the clinical photograph here. It showed a severe capsular phimosis with a contracture with phimosis, and left eye showed a posterior subcapsular cataract. The fundus examination in the right eye was poor due to 2 reasons. One is due to the capsular phimosis, and other was due to the associated vitreous hemorrhage. Left eye had a stable fundus. The B scan also correlated, showed that vitreous hemorrhage and TRD. Considering these findings, with the phimosis around, we planned for a anterior capsulectomy with pars plana vitrectomy. The capsulectomy was planned basically to clear the visual axis for the pars plana vitrectomy. So we planned for a capsulectomy. Here the surgical method was used. Bimanual maneuver was planned, and the radial incisions were given before enlarging the capsulectomy. The pupillary margin or a pupillary dilatation was taken as a reference, and make sure that you try to use as much of curved scissors as possible to get a circular opening in the capsular thing, capsular contraction. So you can take out all the capsular material by membranectomy using a scissors. We could have done with this with the vitrector also, but the fibrosis was a little bit thick, so we used the scissors in this case. After removing the capsular fibrosis, we washed the AC and used a visco to get a maximum dilatation of the pupil by viscomydriasis, and we completed the pars plana vitrectomy. Post vitrectomy, patient had a good visual recovery. I would like to highlight here, most of these complications are preventable. The patients becomes unhappy basically because of the poor surgical techniques, and especially in high-risk cases. So one can plan the surgery beforehand only to avoid these complications, but once recognized, they can be treated properly and effectively managed. Thank you. Thank you for your patient hearing. I would like to thank the AIOSSC Scientific Committee for the opportunity. Thank you.
Thank you, Dr. Sunil. A wonderful presentation, very nice videos. The lead discussant for this particular talk is Dr. Girish Rao and Dr. Arul Varman. I request first Dr. Girish Rao to start with.
Very good videos, Dr. Sunil. I don't really have much comment on the first presentation. I think what you have highlighted very well, the ideal use of the Nd:YAG to do a very minimally invasive technique to solve the problem. And even the second case, I think, was very well managed. The patient was unhappy because of probably an inadequate capsular CCC size during the primary surgery itself. But what you did was very well managed. And I would have done probably the same way. I wouldn't use a vitrector to do the capsular enlargement because it becomes a little uncontrolled, especially in a thick capsule which is stuck to the lens. It's very difficult to get the bite of the capsule into the vitrector, and sometimes you might actually end up chewing up the iris. So I think it was very well managed, and I don't have any further comments. I think what you have done is apt to make an unhappy patient happy.
Thank you, sir.
Dr. Arul Varman, sir.
The same issue, I concur with whatever my co-chairperson has said. The first case was a moderate contracture, which could be handled very easily by doing a YAG capsulotomy anterior, which opened up the capsule and then let the lens go back to the normal position. So identifying this and doing it was fantastic. The second case was a very bad capsular contracture with retinal problems. So you need to have a good visualization. Trying to do a YAG in that is going to be very difficult. As the pupil is very small, a vitrectomy also would have been difficult. There's no other go but then to do a manual scissor cutting of the anterior capsule, which is done beautifully. And once this opens up, everything is fine. Now, there are some issues here. How do you prevent this? Doing a ideally sized capsulotomy to start with would give you some amount of preventive measure from this occurring. But in some cases, in spite of the best intentions, the best done capsulotomy, phimosis still occurs. This occurs due to probably something like pseudo exfoliation already being present in the patient. So you look at these conditions. If the pseudo-exfoliation present, do a larger than normal capsulotomy to start with. So you will not end up in this situation. But you may still find these occurring with the best done procedures. So you would handle it as it comes up and do the best that's possible for that particular patient.
Thank you, sir. Wonderful presentation, Sunil. I think Dr. Srini is ready. I think over to you, Dr.
Thank you, Anand.
Yeah, Dr. Balla, Dr. Srini, are you ready?
Yeah,
Yes.
Amit.
Yeah, Dr.
You have
Srini.
the slide now? Yeah.
Yeah.
So I would once again invite Dr. Srini Adlakhan to give his presentation on post-op unhappy patient with strange complaints. You are ready, Dr. Srini? Can you start sharing your screen?
Dr. Srini, you are still not audible.
Audible, Dr. Srini.
You are not audible, Srini.
Not audible.
No, you are not audible.
Yeah. We can't hear you, Srini.
Yeah, give me one.
So till Srini fixes up, let
No,
me introduce Srini.
we heard Srini for a second.
Yeah.
Dr. Srini, can you speak?
Amit, you can
Some
project it
signal
right
problem.
I can introduce him.
Yeah.
Can you hear now?
Yeah, Srini.
I can hear you, Srini.
Perfect.
Can hear you. Srini, just let me introduce you. Dr. Srini was the immediate past secretary of Kerala State Ophthalmic Society. He is the medical director of Comtrust Charitable Eye Hospital. And he is known for his various national and international publications and presentations at various forums. And the landmark what he created was conducting 38 camps in the state of Kerala for the flood victims in the year 2008. That was a remarkable landmark camps conducted by Dr. Srini in a single day, 38 camps in Kerala for the flood victims in 2018. So that's great, Srini. Over to you. I hope your audio is audible now. You have to unmute yourself, Srini.
Yeah, can you hear me now?
Yeah, now you're audible.
Yeah, good, great. Okay.
You can start sharing your screen, Srini. Yeah.
Okay. Thank you, AIOSSC, for this opportunity. Thank you for the introduction, Dr. Amit. So basically, I'll be sharing my experience on managing a few of the cases which were not really happy post-operatively. My cases and the cases that I had to manage in the OPD. This patient, post-cataract surgery, had a very good vision, absolutely quiet eye, operated elsewhere. Though the patient had 6/6, the patient was constantly complaining of poor vision. And his complaint was the intraocular lens has not been put. And he says that surgery has not been done properly. See, the basic issue here was that the surgeon was constantly on phone during surgery. So, so from whatever Tamil he could understand, he's basically Malayali, had gone to Tamil Nadu to get it operated. From whatever Tamil he could understand, he got a word, "podomate," so which means won't put. So he understood that the surgeon is telling somebody that she's not going to put the intraocular lens in that case. And he's also worried that the surgeon was actually was not really concentrating on the surgery. So the patient is absolutely unhappy. So what could I do? So I had to take care of this patient and I had to protect the surgeon also. So while examining, I kept on commenting positively about the excellent surgical results, high quality of the intraocular lens put. I praised the skills of the surgeon, then explained regarding what is aphakia, pseudophakia. You can't see without an intraocular lens inside. With great difficulty, I could convince the patient that everything is okay with the eye. So, see, what is happening is that we are taking cataract as a very well, we are trivializing cataract surgery. We are taking it as a routine procedure, and we see whatever good surgical results that you give. If the patient doesn't feel that you are actually taking good care of the patient, he'll never be happy. So this is another patient whom I have operated 1 year back. So the patient came back to me 1 year after surgery. Vision was good. No ocular complaints at all, 6/6. But the patient had a stroke 6 months back. That is 6 months after the cataract surgery. And she says that the stroke happened because of my cataract surgery. See, I explained everything like this is absolutely not possible, absolutely not possible. But I'm not sure that I could really convince the patient because, see, I'm from North Kerala. See, our patients never talk or never complain like this to us. See, from her slang, because hundreds of slangs in Malayalam. So from a slang, I could understand that she is not from North Kerala. She was, in fact, from Central Kerala. And I called up Dr. Radharaman. He's a big-time surgeon in Central Kerala. He said he sees these sort of patients day in and day out. So he told me about one patient. See, the patient had a very good postoperative vision. But he's insisting that he didn't get any benefit from the surgery, though the hospital has made a good profit from the surgery. So no benefit at all. So Dr. Radharaman said, okay, I mean, you got good vision, right? You came for vision. Yeah, I got good vision, but I didn't get any benefits. So on repeated inquiry, he said, he says a shop
1 minute left.
TV. So he gives like a stabilizer with the TV. See, he was expecting a similar benefit. So he didn't get that benefit, like free glasses, and he's not happy. See, that's a problem here. See, I don't get patients like that. As I said, people in North Kerala, we are violent politically. There might be murders and all happening, but like Fairuz from North Kerala, we are all very, very nice. Our patients are very nice. But if that patient, in fact, comes to me, I would manage it in such a way that it's a charitable hospital, whatever profit that we get from the surgery is used to help poor patients. And he's actually doing a charity work by getting his cataract surgery done in our hospital. I'm not sure if it would work in Dr. Radharaman's case, but I mean, it's for the panel to decide if that can be done. See, the basic thing is that you have to anticipate. We have to spot the patients who might be troublemakers from the beginning itself. It should not let this happen. So this is see, the patients can be identified from the time they come for the car parking. They make a ruckus there in the reception. So in those cases, don't advise surgery. Make the patient request the surgery. Make it the surgery his or her choice. You communicate with the patient. Treat him as an individual, not a cataract case. The weirdest, I've had hundreds of, I have only 4 minutes, so I'm just telling, this is the last one. See, the daughter-in-law severely complaining that the mother-in-law is finding fault with her because she has started seeing clearly post-cataract surgery. I don't know what, how to manage the situation. Thank you.
Srini, let's have our expert panelists answering your questions now.
That's very interesting problems which you have said. I think these are social problems. Imagine the patient getting 6/6 is complaining. Imagine if he had got suboptimal vision after surgery, what would have been the magnitude of the complaints? So I would invite the lead discussants for this interesting problems. Dr. Girish Rao, please. Sorry, Dr. Girish Rao, please, sir. Are you there, Dr. Girish?
Yeah. I think I'm completely stumped with the choice of this patient's complaints, right from the mother-in-law to the no benefits. I think this is absolutely, as he rightly said, we just need to communicate. And I think the one point that you said, that the choice for surgery, especially for a cataract surgery, if the request comes from the patient, I think that's more important rather than we pushing. And sometimes I do feel that nowadays we put too much emphasis on the quality of vision. So even patients with 6/6, 6/9, just because of mild glare or because of refractive error, they are being pushed into surgery. And these are the patients who are actually likely to land up with an unhappy situation. So I completely agree that the request should come from the patient for the surgery. That would be another way of making it a win-win situation for both. And also probably it also brings in a situation where video recording the consent would probably be of the order of the day, so that sometimes the patients say that you didn't do it, you didn't tell us all this. So we have this kind of a thing which can be tagged to the patient's file and can always be used in case the patient does go to the consumers or any other legal steps. Thank you.
I think communication is the key, you rightly said. Now, can I have the comments of Dr. Y.L. Rajshekhar also, sir?
Yeah, thank you, Dr. Balla. Srini, very well presented. There are very few, very important points here. Similar situation we also face. One thing with regard to the operation theater etiquette, that's extremely important, that our communications have to be, we should not have any negative words of whatever kind. And communication should be minimal or nil. Otherwise, patients will tend to misunderstand that. And because of this, patients across states move around for surgeries. That language barrier also comes in the way. Like, you said the Malayalam patient getting operated in another state. Probably surgeon thought she may not understand that language, and he was on his own. So that should not happen. And then while communicating, again, this in Bangalore, we get patients from across India, sir, all states, patients from all states. In communication with regard to their, each one has a different cultural background under which they understand what we are communicating. And hence, whatever we are trying to say has to be very contextual. We should get to that, their level of understanding, and then communicate. And in Kerala, Srini has a huge problem. Patients will try to find faults with every other thing. So he has been handling that. And it's news to know that even different dialects are causing different problems. It's surprising. So it's a newer challenge. But we have, in fact, this is an apt case for surgeon is at his best. Everything has been done well, but patient is unhappy and patient is trying to blame you. In fact, this is superb thing. Like all of us should be aware of this. We should handle that. Should take preventive steps in that direction and educate everybody in the team. Such things can happen.
One question to the panelists over here. Would you all encourage listening to music when you are doing cataract surgery? High volume cataract centers, they play, somebody plays meditating songs, somebody plays Bollywood, somebody plays Tollywood, Collywood, Hollywood, everything. So is music allowed to play into the operation theater?
I think there's nothing like an allowed. I think you need to talk to the patient. If the patient is comfortable, then you do. And we have some surgeons in our system also who do that. They talk to the patient and then also explain to them the choice of songs. Either it could be a song or an instrumental or whatever. Because sometimes you also need to honor the religious aspects. So you cannot have a Hindu thing going on when you're so. But I think another important point is in terms of the etiquettes, where as an institutional policy, we do not allow mobile phones into the operation theater. I think either for the surgeon or for any of the assistants, any calls should be outside the theater.
Same thing. Mobile phones. From NABH point of view, what is your advice, Dr. Nirmal?
Thank you, Amit. I think there is recently a paper on playing music in the theater to reduce patient anxiety. It does helps. And second way of looking at it, some patients do complain that doctor was listening to the music and the team was not focusing on the surgeries. In fact, there was a complaint in Tamil Nadu that during the surgery, doctor was listening to the music in mobile phone and not focusing on surgery and discussing with the team about some elections and not concentrating on surgery. So if you tend to get a bad result, the patient tend to equate that with the theater etiquette. Right? Somebody pointed out theater etiquette is very important, and we need to make, particularly most of our patients are under local anesthesia. They listen to each and every word, both positive as well as negative comments. The other way of looking at it is definitely need to have a public address system. So that gives you confidence that that PA system is working, and in case there is any issue, call code blue or code red. It's easy to contact your team members outside the theater. So I look at this aspect, soft music, instrumental music, not religious, and better not have patient preferences, just some music that's going on to.
Like how we have in our five-star hotels lobby, some soft music going on.
Yes.
We can just play that to soothe the patient and to the surgeon himself also.
Yeah, what is patient choice may not be the choice of the surgeon, and what is the surgeon's choice may not be the likely the choice of the patient. So we have
Nirmal,
to
what would you
take
say that instead of surgeon listening to the music, if you put earphones into the patient's ear and so that he listens to the music of his choice, that way you also obviate that he's not listening to any talk inside the OT and what surgeon is doing, what he's talking to his team, and he's totally cut off from the surgeon's words. What do you have to say to that? I think that is more safe.
Provided patient is used to hearing music through his earphone. If they are
And
not used to,
if the fluid sweeps through the drainage bag, you are losing your headphones.
The patient can be asked to get his own headphones. Yeah. I think that publication is very interesting. Yeah, that publication is very interesting regarding the music. It does help, I think. A lot of centers are
the
using
thing is, if patient is listening to the music, they may not like or listen to your instructions, looking at the microscope light or
very true, very true.
Taking instructions.
Yeah.
Most of our elderly patients have hard of hearing also.
Yeah.
There's one particular aspect that we are talking about when we are talking about these unhappy patients and in 6/6 vision and all. So in oculoplasty, we talk about psychiatric evaluation of the patient, because some patients who have body dysmorphic image, no matter how good a plastic surgery you do, they will come back to you for 5 surgeries. So we are MBBS, so we are supposed to know a little bit of psychiatry, just enough to find out that the patient is frank schizophrenic, otherwise he's going to be after you for the rest of your life. So a little bit of psychiatry you need to know, so that you know for sure that a person who's coming in front of you is not somebody who's going to stab you, because one of my teachers had got stabbed by a patient who was suspicious that the doctor is out to kill him. So a little bit of psychiatry, a little bit of evaluation is something that you need to know, just to be sure that you're not dealing with a very dangerous patient.
Very true, sir. I think now I would invite my dear friend, Dr. Amit Porwal, to take over and introduce the next speaker.
Yeah, thank you, Dr. Balla. So we have our second last speaker now, Dr. Veer Vikram Singh Chillar. Dr. Veer Vikram Singh Chillar did his MS from PGIMS Rohtak. After doing his SRship from Venu Eye Institute, he's got training in glaucoma from Arvind Eye Institute, Madurai. He specializes in cataract and refractive surgery with special interest in glaucoma. He has presented papers and ICs at national and state forums. He is known for his high volume phaco surgeries of doing about 80 to 90 surgeries in a day. So over to you, Dr. Vikram. Please share your screen. And again, a gentle reminder to everybody, your time is of 4 minutes. You'll get a reminder from Sunil at 4 minutes. So Vikram, over to you. The lead discussant for Vikram's case will be Dr. Prateek Vyas and Dr. Nirmal Frederick.
Thank you, Dr. Amit, for such kind words. Thank you, AIOS, and especially Dr. Partha for giving me this opportunity to present a case. My unhappy patient.
Vikram, we need to go to the next slide.
Yeah. My patient is a 45-year-old young lady with mature cataract in her left eye. We did a topical temporal phaco for her. It was an uneventful surgery, but now see how the things go out of hand. First day post-op, the patient had a hand movement close to face with the striate keratitis, descent fold. We could see a small, around just 1 mm descent detached around the temporal tunnel. We thought we would be able to handle it. So we started the patient on oral prednisolone, increased the frequency of her topical prednisolone acetate drops to an hourly, and also started hyperosmotic drops. Now on the third post-op day, the patient, it is with the status quo. There's more epithelial edema, stromal edema, and the descent fold have further increased, and the descent detachment had increased to around 3 mm. So as a remedy to it, we thought to do an air tamponade for this patient. We took her to the OR and filled her AC tout with air. And after that, her IOP was around 58. So we gave her a Diamox as she was complaining of pain. An hour after giving her Diamox, her pressure was around 48. So we discharged her with the advice to take tablet astazolamide SOS. And now on the fourth post-op day, everything spiraled out of hand.
patient reported to me with a lot of pain and discomfort. I couldn't sleep the whole night. The pressures were high, the slightly clear cornea in the center, but there were still desperate folds. The air bubble had nearly vanished. There was a minuscule air bubble at the superior part, and whole of the iris and the lens had come forward, and there was touching onto the endothelium. So I thought, oh, so I have made her land into malignant glaucoma, so I'll have to handle her as a case for malignant glaucoma. So we gave her injectable IV mannitol, put her on acetazolamide 4 times a day, increased the frequency of prednisolone acetate, and put her on anti-glaucoma brimonidine, dorzolamide, timolol, and even started atropine drops. 1 week post-op, the patient is still very unhappy. The situation is more or less the same. A slight improvement in the vision, but the patient felt very weak because of the side effects of acetazolamide. Though we had still put her on sirapotlor and had asked her to take potassium-rich diet. And the AC was shallow, or I would nearly absent, 360-degree iris touching onto the endothelium. And even the IOL was there still on the endothelium. And the patient was not now ready to take any more acetazolamide. So we took her, we again gave her mannitol and thought to do, plan to do a YAG PI and an anterior halodotomy. We did 2 PIs, one at 10 o'clock and one at 1 o'clock position, and tried attempting a halodotomy. So though we don't have much of an experience in doing a halodotomy, but we did a posterior capsulotomy and slightly
1 minute left.
Defocused posteriorly and did a halodotomy, and continued the patient on topical drops. And though they, as we had stopped her acetazolamide tablet, we added letonopros to it. So 2 weeks post-op, now the vision had slightly improved to 660, but the AC was still shallow all over, except little deepening at the point of PI. The IOL had moved a little backward, and the patient vision had come to 660, but now there was a lot of pigmentation present in the AC and on the endothelium. And the patient was grumbling a lot. She was not ready to see me, in the sense she was not at all happy being in my clinic. Another 2 weeks after her surgery, the vision is still 6/60, and there is iris is still attached all over the endothelium. Though the IOL has gone back and the vision is slightly better, but the pigmentation has increased a lot. And we thought and we discussed with the patient to do AC reformation, surgical.
4 minutes are up.
I'll just take less than a minute. Surgical separation of the iris and do a surgical PI. But the patient said, no, मैंने अब आपसे कुछ नहीं करा. I had enough of you. Unfortunately, like my other colleagues, I couldn't satisfy my patient, though I had been discussing with my couple of friends, even with Amit, I was discussing and we were talking about how to manage, but unfortunately we couldn't do it. So this is the OCT picture. At 4 weeks, there's a diffuse corneal edema in OCT, more so in the posterior layer. There is thickening of the Descemet membrane, and the thickness of cornea is around from 715 to 727. The other eye was 498. This is her picture at 4 weeks, though the picture may not be very clear, but these are, you can see the slight formation of AC inferiorly, and then there is a lot of pigmentation clumps over there. All the pictures we'll see are of the 4 weeks. A lot of pigment clumps are over here on the endothelium. This is the same. This is now retroillumination. You can clearly see a lot of pigmentation. The eye has gone back. That's the Descemet folds. So what I have basically learned, some few points I've learned from my mistake, but I would like the honorable and the learned faculty to guide me, because I'm still. I should have stopped cycloplegic before injecting air, because as a routine we use Homide HS after surgery for 4 to 5 days. I should have put my patient pilocarpine drops before putting an air. I should have kept the air maybe for an hour or so and maybe done a partial air fluid exchange and a strict supine position for the patient. Unfortunately, like the rest of my colleagues, I have not been able to make my patient happy. Still, she is very angry with me. She's very cross. I would like the jury to guide me what all mistakes I have done and how could I have done it better, so I don't ever repeat these type of mistakes. Thank you.
Thank you, Dr. Vikram, for showcasing an unhappy patient. And as I told earlier, it takes courage for one to display the unhappiness of a patient on his forum. So now I invite Dr. Pradeep Vyas and Dr. Nirmal Frederick, our lead discussions for this particular case. So over to you, Dr. Pradeep Vyas.
Yeah, thank you, Amit. Very interesting and very fear-causing presentation. Obviously, in my opinion, this patient did not have the pupillary glaucoma and did not have a capsular distension syndrome, and it was a malignant glaucoma only. And if you have a patient with a malignant glaucoma, he did the PI, he did the anterior hyalotomy and the capsulotomy, and still the AC was not formed. So you have a limited breathing space because it's almost kind of a semi-emergency. So immediately he would have taken the patient for the vitrectomy, and along with that vitrectomy, the AC reformation. And once the time passed by and the iris is in contact with the trabecular meshwork, there is more damage to the trabecular meshwork. So after that, opening the angle space will not help anyway in reducing the intraocular pressure, and patient would require anti-glaucoma surgery. So earlier is better. Reform the AC, do the vitrectomy, and probably do the synecholysis at the angle and push back the iris. So probably your trabecular meshwork may become little functional and the pressure may go down, and the patient might be controlled subsequently just on a couple of anti-glaucoma drugs. He waited very long for this, and waiting very long for this with such a high pressure definitely would have caused significant amount of damage to the optic nerve head as well. So obviously, once you are putting the air into the AC, you have to put the pilocarpine, and you have to make sure that the air should not cause any pupillary block. So that is what all I have to say.
Dr. Vyas, actually, this case, Vikram did discuss with me, and we thought an early vitrectomy would help in taking into consideration the malignant glaucoma. That would help. But we consulted 3 or 4 retina specialists, and all of them told us, just wait. Medically controlled, don't take the patient for vitrectomy. So that's how he landed up in this, because I remember he was constantly calling me up, Ki, I am planning this, I am planning this. I also was discussing the thing. 4 retina specialists, all 4 told, please wait. So we was under the things, book knowledge is something else, and an experienced retina specialist is telling something else. So that was great.
The retina people are notorious for causing the glaucoma. So beware of them. Take your own decision.
So what about
you
Dr.
call
Pradeep
Dr.
sir?
Krishna in your OTA and he will do a nice vitrectomy. Don't ask him to suggest on that. Give him an order.
I do concede that we cause a lot of secondary glaucomas, but nowadays our threshold for vitrectomy is very low. I'm surprised that it was not advised. We look at an opportunity to do vitrectomy in patients. So
that was the contradicting statement which we got from retina specialist. I think even Vikram was planning to go ahead, but then I told them, why 4 logon ne mana kiya. Now it is your call, because he was so tense with this patient. The patient was constantly grumbling. So over to you, Dr. Nirmal, your views?
Yeah. I agree with Dr. Pradeep that vitrectomy should have been tried earlier because apart from the raised eye pressure causing severe pain and disturbance to the patient, the acetazolamide for long term, that actually causes more trouble because it's not a safe drug. It causes in certain high risk patients, particularly elderly and patients with diabetic neuropathy, it aggravates the neuropathy, and from the problem with the eye it shifts to his general problem. So he becomes really anxious about the drug induced problem, and added to that the discomfort of not seeing and repeated visit to the eye care. The second thing I want to note is when you do a daycare procedure, when you discharge, the patient should not be in pain. So distending the anterior chamber and with medication which are causing side effects and sending the patient home with pain, I think it's not a good idea for a daycare institution. We should admit the patient, take care of the pain relief, and then only send the patient home. So pain relief is one important aspect and one of the standards of giving good care. And that's one of the reason the regulations point to that you should have at least 2 beds and emergency management of patients, particularly when you are doing daycare procedure. So these are some points I would add to Dr. Pradeep, and I was really surprised. Nowadays, retinal surgeons are very happy to take any patients, whether you drop lens or even give a slight hint of doing vitrectomy. It's surprising that there was a delay of almost 2 weeks now.
Dr. West, I'd like to ask you, what could be the cause of malignant glaucoma in this particular patient? Uneventful surgery, slight despite detachment, air tamponade.
What I personally feel that initially, the starting point might be a pupillary block because of the air, and then the air got absorbed, and the pupillary block did not relieve, and obviously there was a aqueous misdirection. So that is probably, I can create the sequence of events for causing the malignant glaucoma.
May I just
Thank
Another
you.
thing
have a
could be
word,
the
I
definite
invite Dr.
detachment.
Partha Viswas,
Yeah,
our
Dr.
chairman, our
Parthas.
captain of our scientific committee. He is here. So, Partha, welcome to this webinar. I'm sorry you are the chairman, but you have joined us now. So, welcome and over
very
to you,
sorry. I'm
Partha.
Now, we are
extremely
all very
sorry.
happy to see you back, Dr.
I
Partha.
was traveling and
Is back.
very poor connections. Extremely sorry for
I
this.
know. Sir, you are in the verge of such a wonderful this thing, sir, the important meeting in your life. So that is also very, very important. I think probably invitation and all the part.
Thank you. Wonderful presentation, Vikram. I really congratulate you on showcasing this. I think most of us, and especially in private practices, we tend to keep having such scenarios. One thing that if I could just add, you mentioned that the patient was quite disturbed and said that ab kuch nahi karwana hai. So didn't even want a second opinion. So most of these cases, and where it's very baffling and one cannot get to the end of it, and a proper course diagnosis and the treatment is not there, and patient is not has expected all these problems to come in. So what we do is, in our group practice, we take multiple opinions. Ye bhi dekh lo, ye bhi dekh lo. So the patient moves from one unit to the other, and 3 units, and the patient feels that, yes, not only feels, but satisfied that, yes, I'm being taken care of. Multiple people are giving their opinion and a solution. So the patient doesn't get upset because there are so many different difficulties that the patient is encountering. So one possible thing that we always do is that take multiple opinion immediately when the patient is going wrong, whenever things are not going the right way.
They will feel that the doctors have made the cartel and they favor each other.
Thank you, Dr.
Sir,
Partha.
just
Now
one
we
question.
go with the last
Yeah.
presentation.
Amit, can I just ask one question to
Go
Dr.
ahead.
Pradeep? How long, Dr. Pradeep, would we have, could we have tried the medical management with atropine ointment 4 times a day and hyperosmotic agents? Would they have helped? And if we had tried, how long should we have tried, sir, before undertaking vitrectomy?
See, that everything depends upon that how much is the pressure, the damaging IOP. The damaging IOP is such a high, then obviously you cannot wait. It will damage your cornea, it will damage your optic nerve, and it will cause so much of pain and agony to the patient. So earlier is better. If the patient is comfortable, if the pressure is around 30s, so you know that the patient can tolerate the pressure, the optic nerve not be compromised. So there you can take a chance and you can put the patient on atropine. And many of these patients respond very well to the atropine. And sometimes you have to continue the atropine drop for years together, because once you take off the atropine, then again the pressure goes up and the AC becomes shallow. So atropine does help, but not in this kind of acute patient.
So thank you everybody for your expert comments. Now I invite scientific committee member Dr. Somshila Murthy to go ahead and moderate the last speaker of this session. Feroz, you are there? You are connected?
Yes, Amit, I'm
Welcome, Feroz.
outside.
I request you to moderate the last session.
All right. Hi. Good evening to everyone. Sorry for the technical glitches that I'm facing here. It's my pleasure to invite and welcome Dr. Muhammad Shahid Alam, who's a very young and vibrant oculoplasty, ocular oncology consultant, who is currently heading the Orbit and Oculoplasty Department at Shankara Nethralaya, Kolkata, and his main area of interest being orbital and adnexal oncology. And he's an avid reader and a great researcher who has published a lot in various journals. And definitely, we are looking forward to Dr. Shahid's presentation today, where he's going to tell us about a chocolate that he hates. Over to you, Dr. Shahid.
Am I audible?
Yes, you are.
Yes, you are. Thank you, Dr. Somshila, for sharing the slide.
You're welcome. The discussants for him are Dr. Sunil Morikar and Dr. Nirmal Frederick.
Yes.
Yeah. Are my slides visible?
Yeah, they are visible.
Yeah, so at the outset, I would like to thank the AIOS Scientific Committee for giving me this opportunity to present my case. So without much delay, I'll start with my case. So this is a 2-year-old male. So the patient had actually presented to me 1 year back with left eye proptosis. And this is the MRI imaging picture which the patient had at that time. And it clearly shows multicystic mass in the supromedial and the infromedial intraconal space extending to the extraconal compartment. So based on imaging, I made a diagnosis of orbital lymphangioma and advised intralesional bleomycin to the patient. However, the patient was lost to follow up, and then he reported to me after 9 months with this sort of a clinical picture. So here you can see that there is a marked proptosis with chemosis, and a little bit of dystopia is there. Because of the financial constraints, I did not repeat the MRI, and this much of the imaging picture was enough for me to go ahead with my management plan. So at this stage, I advised aspiration of blood along with intralesional bleomycin. So patient was, however, posted after a week, and this was the patient's picture when he came inside the OT. So obviously, as you can see, the patient has bled a lot in the lymphangioma has bled. There is massive proptosis, there is chemosis, and there was exposure keratopathy too. So I aspirated around 20 ml of blood, both from the superior and inferior orbital compartments, and 5 unit of intralesional bleomycin was given according to his weight. Patient was kept admitted for about 2 days and was given intravenous steroid to take care of any associated inflammation. In addition to it, on table, I did a central tarsorrhaphy for the cornea to heal. Patient was then discharged, but then he presented to me a week later with this sort of a picture. You can see the central tarsorrhaphy which I did was in place, but then there is massive bleeding again inside his lymphangioma. The patient had upper respiratory tract infection too, and was coughing. So at this point of time, rather than lymphangioma, I was much more concerned about the orbital compartment syndrome because of this massive proptosis. The patient was taken to the OT as an emergency basis, and I did a lateral canthotomy and cantholysis. Both the two of the lateral canthus were released. Around 20 ml of blood was aspirated, and I injected again 5 units of intralesional bleomycin. Because of his URTI, he was started on oral antibiotics, and a pediatric consult was sought. Patient was then in follow-up with me, and after 2 weeks, this is his picture. The proptosis has reduced, but then again there's inferior chemosis. The patient has developed exposure keratopathy and little bit of corneal infiltrates. At this point, I got a repeat MRI done, and it shows that
1
the
minute.
size of lymphangioma has increased. There are multiple bleeds. So there might be a possibility that the size of lymphangioma would have been constant, and this would have been the picture at the presentation because I had not got a repeat MRI done when he presented to me after 9 months. So again, a cornea consult was taken, and the cornea people advised a amniotic membrane transplantation for the surface protection. So patient was again taken up for third dose of intralesional bleomycin, an amniotic membrane was placed, and a lateral tarsorrhaphy was done for protecting the cornea. And this time, luckily for me, the patient responded, and this is a picture of the patient. After 3 weeks of his surgery, the amniotic membrane was disintegrating, and the proptosis had reduced markedly. But then, if you compare with the presenting picture, you can see that there is a lot of improvement in the proptosis, chemosis, everything. Then why the patient is unhappy? With this eye, he cannot fixate the
4
object.
minutes are up.
He's just following the light. So obviously he had developed compressive optic neuropathy during the episodes, and the vision is compromised in that eye. There was RAPD present in that eye. So this was my case. And lymphangioma, like they are venolymphatic malformations. They are notorious for intralesional bleed, and that was they called chocolate cysts. Upper respiratory tract infection is a clear risk factor both for increasing the size of lymphangioma and bleeds. And management, of course, is challenging in these cases. And what were the challenges in the present case? There was massive recurrent intralesional bleed, which was not responding to the management. Patient had developed compartment syndrome because of massive proptosis, and then patient was a pediatric patient. An adult case can be taken to OT n number of times for different minor procedures, but a pediatric patient has to, every time when we take him to OT, we need a general anesthesia. And lot of general anesthesia under such a short duration of period is risky for a pediatric child. And of course, in a case of lymphangioma, we have very limited surgical options. So that was my case, and this is how I managed. I would like to request the panel to come up with ideas and other issues having managed differently. Thank you.
Thank you very much, Dr. Shahid. It's a very challenging case, of course. So, venolymphatic malformation of the orbit is a troublesome lesion. So, we have our esteemed panelists, Dr. Murekar and Dr. Frederick, who will take the discussion over. May I request Dr. Murekar to take over the discussion? Over to you. Thank you so much.
I have a lot to say on this, so I would rather have Dr. Nirmal Frederick start talking about it so that you can cut me short when the time is up.
No, it's
Nirmal?
first choice, Morekar. Sunil, go ahead.
No, please go ahead. I mean, I would love to hear from you from the different aspects which are involved in this case.
Okay, first of all, I think it's an unfortunate case for a pediatric patient. And of course, the title was interesting and sweet, but the case didn't go as sweet as the title sounded. Of course, recurrent bleeding in case of lymphangioma, we read a lot about that, but handling it in a pediatric patient is going to be a real tough job. And of course, patient lost the vision because of the sudden bleeding within the orbit and optic neuropathy, consequent optic neuropathy. Right, how different you would have handled, and the unhappiness because of the vision loss. Obviously, with so many surgeries, patient would expect some vision, but if you have counseled very well both the patients and the parents, and they would have seen, because this is nothing unseen. They would have suddenly seen the proptosis twice or thrice increasing in size, repeat admissions, repeat surgeries. So obviously patient and the parents would have been counseled well. So this unhappiness because primarily because of the vision loss and also repeated admissions and surgery. So how to tackle this? Of course, the vision loss have to be explained to the patient, and also good rehabilitation also has to be given since school going patient. And parents should be counseled that this can again recur, and it can increase the proptosis as well as the unsightliness and as well as the corneal surgeries that are needed. So how well you could have handled, of course the disease is not now under control with bleomycin, need to be followed out properly. I was surprised at the huge proptosis and also repeat bleeding within the short span of time. So lymphangioma, I think if it is responding to bleomycin, we can handle. And the second part is rehabilitation, both surgical as well as the visual rehabilitation part. So that is a daunting task to keep the patient happy. So Sunil, how would you tackle the orbital part?
So as far as I'm concerned, I would look at it from 5 different aspects. So this is extremely well managed and it is brilliantly managed, and the end result, except for the vision loss, which is possible in these cases. So I will look at it from a medical legal point of view. We know for sure that vision loss is always a possibility with a lymphangioma, with recurrent bleeds and with orbital syndromes, even if something was not done by the doctor. So there is a possibility. We have had cases in whom there has been an injury and the child is bled and there has been a compartment syndrome and the vision has been lost. So from a medical legal point of view, it would be essential that the patient, when the patient, to not allow the patient to be unhappy. I mean, I will deal from that point of view first. Is when the patient comes in here, you tell the patient this is an extremely daunting kind of disease, and the treatment can be long standing, that the things can be recurrent, the course is not predictable. So all of this has to be very nicely explained to the patient. Initially I used to rush into things, but nowadays my counseling takes 2 hours. So some patient like this, my counseling will go on for 2 hours even before I touch the patient. So this is something. And then the other aspect is, because it is a child, from a medical legal point of view, you sometimes, I face patients when the mother gets the child in and the father comes in later on and says that I was never consulted. So a mother and father both being involved when it is a child, medical legally, that is extremely important. The third, from the medical legal point of view, the third thing would be, whenever there is a visual loss, the consent has to have that anything that I'm going to do is going to cause a visual loss. Even if I don't do, it is going to cause a visual loss. So there is something called as informed dissent. So now if you don't want me to do something, that itself might cause a problem and vision loss. So you can't blame me. You are signing that you don't want to do something about it. So there are patients in whom I've said this is all what is possible and the patients have gone away. So that is medical legally. The second thing is, there are cases where I have had lymphangiomas turning out to be venous malformation. So when I've ended up doing a DSA, we find that the roof is, the roof is involved and there is a small leak, and then I inject something and there is a connection in intracranial. So that is one aspect of it. The third aspect is, so there are times when we have found out that it was clearly a lymphangioma and then eventually something went in. So this is something that we have written about it in the British Journal, and we have had a huge discussion about this. The third aspect about which is that systemic conditions. In one of my patients, when the patient's anemia was treated, there was a low flow connection and we didn't find the connection. But when the patient's anemia was treated and the thing shrunk itself, so the heart rate reduces, the anemia is corrected, the bony roof defect goes away. So there are multiple things involved here. We need to involve a systemic aspect into it from our point of view, from the pediatrician's point of view, from a radiologist's point of view. That is something that needs to be seen. And the last aspect is that when we are looking at something like this, I would generally, as Dr. Partha said, involve everybody around me. I would involve the pediatric ophthalmologist, I would involve the squint specialist, because there are going to be things that are going to happen here. And it is not just from a point of view that the patient gets a good multiple viewpoint, because sometimes diseases like this can be elephants and I could probably be a blind man. So I want other people's opinion in this. And so from that point of view, plus what Partha said, that the patient understands and knows that he's been well taken care of right from the beginning. So if the patient has met multiple people, he has understood pediatric ophthalmologist saying that there's a squint possibility which will come up later on. There is there is a visual loss which is going to come up later on, has met a glaucoma specialist saying that there could be a possibility of pressure rise there. So multiple aspects are taken care of. So there could be something which should, like these cases, need to go to a board, like cancer patients go to a board. Cases like this, I feel, should go to a board which you can locally form. We need not be in a multi-specialty institute. You can form a board with your friends and say that, what do you think? What do you think? And 4 people get together and talk to a pediatrician and deal with it with a board, and get a lawyer in, get a medical legal consultant in, because these are cases which we have burned our fingers very badly. We have rushed into surgeries, but get a psychologist also involved in it, and get both the parents involved in it, because we have burnt our fingers in something like this. So you may not face that situation ever in life. The last thing that I'm talking about, that there is a case in whom we have spoken about this in grades. When you do repeated general anesthesia to a child, there is a possibility of scholastic ability going down. So my own child, for a dental abscess, we did it under local anesthesia. So we convinced the child, we talked to the child, we did it under local anesthesia. So repeated. So the last part is empathize, be in the patient's shoes, think of it as your own child. Then you will think of multiple aspects, because I have thought of anesthesia, I have thought of anesthesia complications, I have thought of scholastic abilities going down in the child, I have thought of possibility of a connection there. And when I have thought of this problem in these ways, thinking of it as my child, the outlook changes. So I could go on and on this, but I think we are running short of time.
Yeah. So thank you, everybody. Before we conclude this program, I would like one liner, one remark from each chairperson for this particular webinar we conducted today. Just in short, one liner or a one sentence. Your views. Dr. Nirmal, we start with you.
Yeah, so I think most of the presenters did very well. In fact, it should be looked from unhappy surgeon point of view, their challenges rather than the patient unhappiness. I would like it to be focused on patient unhappiness and how to sort it out, because most of this are involved around only three basic functions. One, communication challenges. Second, documentary challenges. And third is tariff or administrative related challenges. Very rarely we fail in the technical aspect, the surgical aspect or the clinical aspect, but most often the medical legal aspect or the unhappiness revolves around the service quality. That's where we need to concentrate, focus more on communication, more chat time, as somebody said, concentrate on giving the right type of counseling. And most often counseling is done by the non-medical people. I think tough cases, the doctor should spend more time with the patient than doing the surgical time. So I would
Thank you, Dr. Nirmal. Yeah. Dr. Rashekar?
Thank you. It was a nice webinar. In fact, in addition to treating the eye, we should treat the person as a whole. Understanding the entire context will help. A lot of learnings, nice presentations, and good
Thank
inputs
you.
from the colleagues. Thank you.
Thank you, Dr. Rashekar. Dr. Rao?
Yeah, thanks to AIOSSC for the invite. I think my learning from this is it's nice to have insights. In hindsight, we can say a lot, but I think this kind of webinars actually adds to our foresight so that we are able to anticipate things and take the corrective steps. Very interesting seminar. Thank you.
Dr. Sangwan is there? Dr. Sangwan, sir?
He's not there. Dr. Arul Mozi? Dr. Arul Mozi?
The AO Scientific Committee for coming up with this topic where you have unhappy patients. We see these, whether minimally unhappy or maximally unhappy, almost every day. It's a simple refraction to some kind of a refractive surgery. It's very nice to have a wide presentation, multiple presentations from a different point of view. Opens up the topic and makes us understand how we would be better prepared to handle these kind of patients. It's a very good program. I think we should do more of these.
Thank you, Dr. Mozi. Dr. Vyas? Dr. Vyas, are you there? Dr. Sunil? In short,
I think the same.
Dr. Vyas is there, yeah.
Yeah, Amit and Partha, it was a wonderful thought of webinar. And I'm sure that in the time to come, more and more people would come out with an unhappy patient. But, in my opinion, the definition of unhappiness is very relative. If the patient is having a vision of 660, then also he may not be unhappy because you must have explained him in details about his condition and all. And if the patient has a vision of 6.6 following the surgery, then also he may be very unhappy and, he's going to see the doctor. So, but anyway, this is a very relative term, but bringing out the unhappiness of the patient because of some medical reason is a very good point. And most of the speakers, the case presentations, they did the justice with their topic and their talk. Thank you very much for including me in this webinar.
Yeah, Dr. Sunil, in brief, one liner.
Something that I have read in my, I have seen it for 5 years at KEM Hospital with a statue of Mahatma Gandhi saying that the patient is the center of our universe. And patient happiness is the core concept that we are rotating around. So unless the patient is happy, or everything that we do is useless. And the second point is that अपनी तारीफ तो सारी दुनिया कर लेती है, और हम लोग डॉक्टर तो हम लोग इसमें माहिर है कि अपनी तारीफ कैसे कर ले. We are all very good in talking very nice about ourselves, but अपनी गलतियां कोई निकालता नहीं है, कभी कोई बोलता नहीं है. So finding out our own mistakes and talking about our own mistakes is something that we should be doing, because that is the cornerstone of perfection. So I would like to always talk about my mistakes, whether it is about the patient, whether about it is communication with the patient, because that is where we will eventually improve. And the whole idea is that when you talk about fixing healthcare delivery, you look at the University of Florida workshop, they talk about if you go into litigations, we get into a culture of hiding. And if we go into the culture of hiding, we will never learn. The medical errors will keep on increasing. So today we are dealing with medical errors. So we have to stop hiding. We have to at least start talking between ourselves. So we do not get into a culture of hiding. So we find out what is a mistake, what are mistakes with us. There might be personality disorders with us. When we are talking to patients, we can talk to each other. We have to find out mistakes about ourselves. It's only when we find out mistakes about ourselves that we will improve. We only have to not get better than the next person. We have to get better than us yesterday or us 1 hour back.
Thank you, Dr. Sunil. So before we conclude, we have one concluding remark from Dr. Namrata Sharma, our Secretary IOS. After that, we have a short presentation of about 3 to 4 minutes. So, Dr. Namrata.
Thank you, Amit. I think it was an excellent webinar in the sense that we came to know all the possible reasons why the patient can be unhappy. Several of the things we learned ourselves. I think it was a great had a great educational value for us also, like Dr. Prasad's case of, 18 years ago, still doing well with a 3-piece and with a SICS, or like the simple thing about toric IOL rotation, which was presented as the first case, or like the last case, which was so devastating, but turned out to be so well in the end. So I think we all have learned a lot, and it's a great effort. And this is going to be there on YouTube, Facebook, so people can always refer back to it, and also those who have not watched can watch it. So congratulations, Amit.
Thank you,
Congratulations to the trials and scientific committee along with Dr. Partha.
Thank
And
you, Dr. Namrata.
all the people who had the
Presented.
all the people who have
Exactly.
courage to
Yeah.
show their cases. And of course, we are, just giving remarks on what has happened or what they have done. But thank you for sharing those cases with us. I think that is the most important thing.
Thank you, Dr. Namrata. Sunil, can we have the video, please? Before we finish the program, can we have a video? So again, this particular scientific webinar wouldn't have been possible without the support of Alcon. Alcon was a sponsor for this webinar. So I thank Alcon for this webinar. I thank our chairpersons, our speakers, our governing council, our scientific committee member, our chairman scientific committee, and everybody at the backstage, Mr. Sunil Pallabi, for helping us with this great webinar. Also, I would like to invite comments from all our scientific committee members before we conclude. So over to you, Dr. Bhalla.
Yeah, I think this has been one of the very nice webinars. We have had series of innovative webinars from scientific committee, and this has added to the value of the webinars which we have conducted. It was one of on a very practical topic, and sincere gratitude to our dynamic president, Professor Mahipal Sachdev, Secretary Dr. Namrata Sharma, for providing us the opportunity, and all our scientific committee members, Dr. Partha Biswas, for coming out with a very novel topic. And thanks to all the esteemed chairpersons, Dr. Virender Sangwan, Dr. Arul Mozi Varman, Dr. Nirmal Frederick, Dr. Pradeep Vyas, Dr. Raj Shekhar, Dr. Sunil Morikar, Dr. Girish Rao, and Dr. Nirmal Frederick, and all the speakers for doing justice to the topic. I think it need really guts and courage to come out with some of the difficult cases. But by doing so, they have not only come out with a panoramic view, what experts would have done. The basic things which we have learned is the counseling is the key. You have to take the patient into confidence, and that is only, otherwise even the patient with 6x6 vision will never be satisfied. I think that's what I'll have to say. Over
Dr.
to you,
Sonu?
Amit.
Dr. Sonu?
I think I'd like to thank all the presenters for, presenting and showcasing the cases. It's very difficult to share such cases. And the basic aim of this webinar was to highlight our own cases and how we can, with small tips, give certain clues to our general ophthalmologist whereby they can come up with solutions for these unhappy patients. And I think very nicely coordinated in the absence of our chairman, Amit, you have done wonders to this webinar. And I'd like to thank President Dr. Mahipal, Dr. Namrata Sharma for giving us this opportunity on the scientific committee platform. I think it was a wonderful being here with all of you.
Dr. Somshila?
Yes, definitely. Thank you to the Governing Council for enabling us. This is in a series of AIOSSC Scientific Committee case files, and we're really delighted that this too went off very well, and we hope to bring more and more innovative platforms and ideas for webinars.
Thank you, Somshila. KP, Krishna Prasad? Feroz?
Hi, Amit.
Yeah.
I would say this is one of the most unique webinar that scientific committee as a team we have conducted, and sincere gratitude to all the panelists, the chairperson, the governing council, and the speakers were excellent bringing out these challenging cases, and I'm sure the messages are very loud and clear, and we have all learned a lot from this. Thank you once again. Thank you very much.
Krishna Prasad, are you there? KP? So I think he's not there. So thanks a lot. Thanks a lot. KP, yeah. Come on.
I am here. I am sorry. Actually, it was a fantastic conducted program. I think, Amit, I could be able to join only in the end part. As Dr. Namrata said that, I think we should be able to, I think it's already there in the YouTube. I think people can watch again and again, and whatever the best possible we can do from our side, we can do.
Thank you, KP. So thank you once again, once and all. Good night, Shubhratri. Thank you.
Thank you.
Bye-bye.
Thank you.